today, like I was saying, it's our last online session. We do have some important things to cover. We're going to be talking about traumatic injuries, so what we can do in the event that somebody has a physical injury, and we're also going to spend the last part of today talking about CPR to get our CPR certifications rolling. So we're going to do like the online education, hear the learning about it, and then when we get to the institute, we're going to do all the hands-on stuff. Now, I did want to start with Mentimeter, so we will just go ahead and do that. I'm going to put up the directions right here. So I'll give you a few moments here to get logged on. I will type the code into chat just in case it's hard to see again. All right. So we had a pretty intense talk yesterday, and part of it was about how kind of hard it is sometimes to be in first response, to be a medical provider. So one of you guys was asking about this, just like what can you do to take care of yourself? And so what I want to ask you is, already in your life you probably have experienced stress and you have found things that help you feel better. So yeah, I want to know what you do to take care of yourself, because that's going to be important. Play soccer, sports, go to the gym, absolutely. Exercise, take a walk, unwind by listening to music and watching TV, absolutely. That's the thing I do. Cooking, also love that. Play with a dog, rest, color, working out. Time by yourself. Talk to people who make me feel safe and loved, absolutely. That is a very important thing. Therapy, absolutely. See lots of outdoor activities, lots of exercising, draw, art, absolutely, baking. Get off the phone for an hour, yeah. Maybe even start trying to bump up those hours. I could work on that as well. Play with your cats. Yeah, I have 2 cats that definitely make me feel a lot better when I'm sad. So good. Now, I just want you to just register these things, because even if you go into this field, these are the things that you're going to want to hang on to, because if you do end up working in medicine, you'll find that it can get pretty busy and it can feel like it's overwhelming into your everyday life. You know, there are going to be things that we do, like night shift, right? If you start working at a hospital or on an ambulance, you might start working night shifts. And I know from personal experience that can be harder to kind of like keep my hobbies and keep the things that make me feel good outside of medicine in my life. So just remember that you always have these things to fall back on. They're never going to go away. You're always going to be able to take time for yourself, do what you need to do. So if you ever start feeling overwhelmed, go back to the basics. Go back to what you love to do, what makes you feel good, right? Now, we did a little bit of this at the end of the day yesterday, but you've had about a whole day to kind of ruminate and think about what we talked about. I just wanted to know if you had any questions or any other comments about our discussion yesterday. If not, that's totally fine. Yeah, I think about Julian a lot too. One of the good news parts of that is that Julian has gotten help since then. That video got a lot of attention, and some people essentially found Julian. And as the last I knew, he was going through rehab, and he had gotten help, and he is doing better. So if that helps you think about that, that helps me too. Okay, so what's the difference between smoking weed and using it as a medicine on your body? So, I mean, the main difference is just how that person gets it into their body. When we were talking about like medications, like epinephrine and Narcan, in there you see that route, right? How it gets into the body. Narcan is intranasal, goes into the nose, and epinephrine is intramuscular, right? So it goes through a muscle. The difference is Essentially what it does to the body. So there are plenty of ways that people take medical marijuana, like topical lotions or tinctures. Um, People eat it as well. The main difference is when you inhale smoke, you are damaging your lungs. Um, you're inhaling a lot more than just cannabis. So there's always the risk of putting extra things in your lungs. So smoking anything is one of the reasons why we kind of don't consider it a huge amount of medicine, especially when you're like, oh yeah, if we're talking about medical marijuana, we're talking about THC that doesn't necessarily have as many medical properties as CBD does. And CBD oftentimes comes in the forms of tinctures or ointments or things like that, which are less damaging to the body. Yeah, exactly. Right? No one really wants to be in that situation. Yes, there are potential things that they can do. However, Julian's likely going to have scars for the rest of his life. If he's lucky, it can heal. But it's one of those things, if you have something like that, it might not completely heal over his lifetime. But in general, the main thing we're worried about is an infection. If he continues to have an infection, that could lead to other issues. So they could do some stuff, but it's going to be a long road of recovery for him. How much of what we learned about yesterday can we do administer as a VEFR? Pretty much everything. I wouldn't really teach you that if you couldn't do it. There are going to be some things, right, that I've mentioned that aren't in your scope of practice, like doing a finger stick. But you can give Narcan, and you can absolutely have conversations with people about their health. You can also, do those medical assessments to try to figure out what's going on. So we're going to do a lot of like very specific declarations of what you can and can't do, and we're going to get into more of that when we're in person. But pretty much everything that I taught you yesterday, you can absolutely do as a VEFR. Can you really not take a child who is going to pass away within the next 24 hours without parental consent? Does that level of emergency not override their consent? No, it does not, unfortunately. That is the hard thing about consent. It is the parent's decision. So again, we can do our absolute best to convince people if they don't want their child to come with us for some whatever reason it is, we can absolutely do our best to convince. That's one of my favorite things about EMS. There is no BS in EMS. If you believe and you know that somebody is in a bad way and somebody's not understanding that, it's your duty to essentially say, listen, I understand your hesitation, but your child will potentially die in the next 24 hours if they do not seek help. Please let me take them to the hospital so your kid does not die. Right? Oftentimes, people will then say, yes, okay. It is incredibly rare of a situation where somebody will not listen to you in a life or death situation. The other thing that comes into play here is that mandated reporter training that you have to do through the state of Vermont. As a VEFR, you will be known as what we call a mandated reporter, which means we're not going to just let it go. If they refuse care, I am essentially going to file a report saying that I believe the parents of this child are abusing them because they are not giving them the correct care that kid needs. But if I forcibly take that child from them in that moment, those parents can call the police. They can tell them that we kidnapped them and we could see some legal action against us. So again, we're not law enforcement. We can try to convince people that what they need is to go to the hospital, but we can't forcibly make them go. No, VEFRs cannot draw up Narcan. You will only be able to give it in a pre-drawn up state. So I showed you those two different applicators yesterday. They all come with Narcan already in them. You're not going to be giving it through a needle or anything like that. It is all intranasal out of one of those preset applicators. Mandated reporter carries into your entire life. This is a really broad question. I mean, I think the main thing is that they show it to be oftentimes fun, or like that there's no downsides, depends on what you're watching. it's really going to depend on who's creating that show or that movie. There are some really good, accurate portrayals of what drug addiction and things do. But I mean, a lot of popular movies and things like that have a lot of drinking and smoking in them that don't necessarily highlight the negative aspects of it. All right, so let's move on. Oop, not yet. Okay, we're going back to our slides. So I do just want to put a disclaimer out there for you. Because we're going to be talking about traumatic injuries, I am going to show you some pictures of some real traumatic injuries. This is not to scare you. It's not to like shock factor you. I'm solely showing you these pictures for educational purposes so that you can understand what it looks like and so then how we can treat them. I also just want to let you know there will be some blood in these images. If you find yourself feeling queasy or not wanting to look, go ahead and look away. I'm not trying to force you to look at it. However, if you do go into the field of emergency medicine, you are likely to see worse. So just keep that in mind. Do whatever you need to do to feel comfortable, but I do just want to let you know I am going to show you some real pictures. Okay, so trauma. Now, in emergency medicine, when I say the word trauma, I mean a physical injury to somebody's body. There are all different definitions of trauma, right? There can be mental trauma as well, through somebody going through hard experiences in their life and having lingering effects from that. But when we're talking about it in emergency medicine, we are talking about physical injuries to somebody's body. That's the difference between like a medical situation, somebody having a heart attack, and somebody having broken bones or open wounds. Now, like we said on the first day, right, the reason EMS kind of became a thing in the United States is because of traumatic injuries, because of car accidents and crashes and things like that. And you can see that this is the 10 leading causes of death by age group. This is still, it's a little outdated, it's 2018, but the stats are the same. It really hasn't changed. Between the ages of 1 and 45, essentially, the main reason why people would die is due to an unintentional injury, a traumatic injury. So there is a large group of our population that is more at risk of, dying because of a physical injury after an accident or something along those lines. That's why it is so important.
If you can think of something you want.
That's why it's so important for us to know these things, because this is kind of one of the biggest parts of EMS, the bread and butter. You are likely going to see physical injuries. Now, I do just want to give a quick review about some of those body systems we covered on Tuesday, because the physical systems are, what is going to be damaged when we're talking about traumatic injuries, especially the skeletal system. One of the things we're going to spend a lot of time on at the Institute is learning how to do trauma assessments, learning how to recognize what a healthy, intact human body feels like versus a damaged one. So our skeleton provides that structure and some good protection for our internal organs. However, it can be broken and that can lead to other issues. So when we do those trauma assessments, we're really trying to focus on assessing the skeleton underneath somebody's skin, finding injuries, potential that we can fix by splinting, or finding open wounds that we can stop bleeding. And again, the huge part of that for us is assessing the spinal column. That cervical spine keeps all of our autonomic functions going, keeps our heart rate going, keeps our breathing going. And so one of the big things we're also going to focus on is maintaining stability in that C-spine and assessing to see if we think there are any spinal injuries. Because the last thing we want is that if somebody has a spinal injury, that it gets worse and potentially leads them down the road towards death. So a big part of being a VEFR is going to be helping people, other providers, essentially provide stabilization to the C-spine, applying a collar that helps somebody's neck stay nice and rigid. And so just a reminder here, the spine is one of the most important parts of our body. We need to protect it on our patients, especially after traumatic incidents. So using things like the jaw thrust too, if we're worried about airway, breathing, or circulation issues, we need to open the jaw, open the airway in a manner that is not going to damage or increase any damage to that spinal column. So when we talk about trauma, we also have to talk about what we call a mechanism of injury, how somebody got hurt, right? If we're looking at a scene, what we want to know is when I just arrive and I see a car accident, I want to have a level of suspicion of how injured I think a person is. And so when we're talking about a high mechanism of injury or a significant mechanism of injury, those are things that oftentimes lead to traumatic injuries that are deadly. So if we arrive to a motor vehicle crash, right? Are we seeing just a little fender bender, right? Not a lot of damage. Or are we seeing cars flipped over? Are we seeing lots of damage to those vehicles? That would make me more suspicious. Other than that, right, if somebody is walking on the street and they are struck by a car, that is also a large mechanism of injury because a human body is not as strong or as dense as a 2-ton, car that is just made of metal. So somebody being struck by a car is likely to have more injuries than another situation. Now, falls are also a big mechanism of injury, especially for the elderly population. Anytime really somebody is over the age of 65 and they fall from a standing height, we start to get worried that they could have a life-threatening injury. It's kind of used as a joke, but like the old lady falls down, can't get up, right? Breaks a hip. That's very common things to happen. And really a broken hip can actually be a pretty severe life-threatening injury. Now, blunt or penetrating trauma, this is really anything that strikes the body hard or enters the body forcefully. So that's going to include things like fighting. If somebody gets punched, someone gets hit by something, falling objects. It could also mean like stabbings or shootings. Motorcycle crashes are definitely a high mechanism of injury. Anytime somebody attempts to hang themselves, that is also a high mechanism of injury because it is directly affecting that C-spine. I think that's supposed to say diving accidents. I keep forgetting to change that. And then also recreational accidents. We do have a lot of people in our state who like to ski, who like to snowboard, who like to do ATVs or snowmobiles or things like that. And anytime you're moving really fast and a crash happens or you fall off or you hit a tree or something like that, that can lead to injuries. So again, we want to have a suspicion of how injured somebody is. If we get called to a motor vehicle crash, again, I want to look for how severe I think that patient might be. And that's all about that gut feeling, right? Oh boy, that car looks really damaged. That person is likely to have injuries versus, oh, it kind of just looks like a fender bender. I don't really think there's going to be any life-threatening injuries, but we should still assess. So we do break it down into essentially 4 different types of traumatic physical injuries that can happen when we narrow it down to the different types of forces that can be exerted on somebody's body. The first one is blunt trauma. So that is anything that strikes the body, like a baseball bat, being in a car accident, a vehicle striking a pedestrian, something along those lines. It's like a wide force striking against a body, most likely to cause fractures to bones, but it can also damage internal organs depending on the force of it. So we might not actually be able to see some of the more severe injuries that somebody has because it's internal. Penetrating trauma, this is anything that forcibly enters the body. So a stabbing, an impaling, gunshot wounds, things like that. Anything that forces its way in, breaks the skin. There can be broken bones associated with it. There can also be internal injuries that we might not be able to see, depending on what entered that person. Now, these last 2, blast and barrow trauma, these are less common. We are mainly going to be seeing blunt and penetrating trauma, but trauma can happen based off of these other situations. So blast trauma is trauma resulting from an explosion. Now, it doesn't have to be like a bomb. There are things that can explode without it being intentional, right? There are lots of things that contain gasoline. There's lots of pressurized systems that we have. And if those explode, they can cause trauma. And then barotrauma, this is trauma resulting from a rapid change in pressure. It kind of goes along with blast trauma because if there's a large explosion, there's a huge change in pressure, air pressure in that area. And we have some internal organs, specifically like our lung, our bladder, and our spleen, that are really susceptible to changes in pressure that can cause damage inside. We also, we're not as likely to see, like people having barotrauma from diving super deep in Vermont. We have Lake Champlain, but it doesn't go deep enough where if you swim to the bottom and come back up, you're going to have barotrauma. But this is one of those things that if you start working in a hospital or in an ambulance service near an ocean where scuba diving is really popular. If people go down really, really deep, they need to have specific circumstances to help them when they come back up because there's so much pressure exerted on them that if they come up too quickly, that can lead to other issues. So now here is one of the more important and relatively easily fixable things that we are going to manage as VEFRs. We're going to learn how to do stop the bleed at the in-person institute, and that means like how do we stop somebody from actively losing blood. Again, this is one of the most common reasons why people die after traumatic injuries is bleeding control. Either they're not able to do it to themselves because they're too injured, or people around them don't know how to effectively stop that bleeding. Now, in order to understand the bleeding, we did go over the different types of blood vessels we have in our body and the severity of bleeding that we might see with them. So starting from the bottom here, capillaries, those are those really shallow, very microscopic pieces of our circulation. If you've ever gotten a paper cut, if you've ever gotten just like a scrape that started to bleed, you are likely seeing capillary blood. And it's slow, it's even, and it's almost impossible for somebody to have, like a deadly injury that has resulted from capillary blood. These are very easy to stop. Most common types of bleeding are capillary bleeding, and we mainly consider these just like very superficial or not very scary types of injuries. Now, once we get to venous bleeding, that is when those veins are damaged. So the veins are bringing that deoxygenated blood back to the heart. It's not super high pressure. So people can have life-threatening bleeds that come from veins. But again, it's going to depend on the extent of that injury. Is it a large cut? Is it a small cut? Some of the ways we can tell between like what is a venous bleed versus an arterial is the color of the blood. Venous blood, like I've been saying, is deoxygenated. So it's going to have an actually darker color than blood with oxygen in it. It's also not going to be spraying out of a wound like an arterial bleed might. So venous blood is usually a slow, steady flow, kind of like a pouring or an oozing, again, depending on how severe that injury is. Whereas if an artery is damaged, those are the high pressure, bigger vessels that are carrying blood away from the heart. So if an artery is damaged, for the first minute or so, you might see spraying blood because in time with that person's heartbeat, that's where the blood is able to leave and it's going to spray. It will also have this brighter, more like hot red, very neon kind of color to it because that's the effect oxygen has on the blood. It makes it a brighter color. So if you show up and you see somebody with dark blood leaving an injury on their arm that's kind of pouring out and it's steady, that was more likely a vein or veins that are damaged. Whereas if you see bright red blood kind of quickly leaving and spraying out of a wound, that would be arterial bleeding. We really need our blood inside of our body. It's what circulates all the stuff that keeps us alive. It circulates the oxygen, gets rid of the CO2. So we basically say that a human body can't really tolerate more than a 20% blood loss of its total volume. So that means in an adult, we can lose about 1 liter. So if you've ever seen a Nalgene bottle, right, that's about how much we can lose before we start to get really close to death. Now this also just depends on size, right? Bigger people have a little bit more blood, and so it's around 1 liter that we see to be like the signal that somebody is on the way out. Now with kids and infants, it goes down. Kids are about half, and so that's about like half an Nalgene. And then infants are about 1 to 200 milliliters because they are so much smaller, right? Can you have internal venous or arterial bleeding? Absolutely, yes. That's one of the things that we need to essentially be assessing for is signs of internal bleeding because somebody gets in a car accident, right? They're wearing their seatbelt, but the car is going really fast and they hit something that stops them really quickly. They can have internal injuries that are actively bleeding that we can't see. So that's why we want to have that suspicion. Oh, you were going 80 miles an hour when you hit a tree, right? You have pain in your abdomen, but we don't see any external bleeding. I'm basically going to be like, I'm really worried that that person is internally bleeding. So Evie, even as advanced EMTs, paramedics, we do not really have any way that we can help people with internal bleeding. They need surgery, right? So that's why it's so important that we are suspecting of it. We can recognize signs so that we can get them to the hospital as quickly as possible where they can get surgery. We can't really do any bleeding control on blood that we don't see. Now, the other thing that I want to point out about this is I say 20% blood loss. I give you this amount of milliliters or liters that is dangerous. But can we actually determine the volume of blood that somebody has lost? And to help demonstrate this, I want to show you a picture. Give me an idea. How much blood do you think somebody has lost here? If you can't, that's part of the point. Now, what I'm also going to do here is, let's just say, do you think somebody lost more blood in this picture or this picture? And why would there be a difference? Yeah, carpet versus tile, right? I actually don't know how many milliliters somebody lost here because it's almost impossible for us to tell. I would argue, I bet this is about the same amount of blood, right? The difference is being the surface that it was on. On the carpet, if it's really thick, the blood is going to soak down and be absorbed by that carpet, versus if it's on a hardwood floor or tile, it's going to spread out and it's going to appear like more. So even though we have these essentially set limits of what somebody can tolerate, on an ambulance, we kind of operate in the idea of a little, a lot, or holy crap, that's a lot when it comes to bleeding. So use just how much blood is on scene to help guide your suspicion. Like, hey, that's a good amount of blood. Or do you just see a few droplets? Do you see a pooling? Do you see congregating blood, like blood in a group, right? That's really what we're focusing on is, did it look like a little bit? Did it look like a bit? Or did it look like a lot of blood? Because that's going to help us determine how scared we are for that person. So life-saving slide coming up. It's not as cool as a medication, but this is one of the most important skills that we have, bleeding control. Now, you've probably been taught what the first step of bleeding control is throughout your entire life. Does anyone know what that is? No matter how big or bad the bleed is, yes, Isabella, you're going to put pressure on it. Direct, hard pressure. Now, when I say pressure, I don't mean just like resting your hand on top of an open wound. I mean finding a hard, flat surface like the floor or a table and putting your body weight like onto that wound. You need to apply really firm, good, direct pressure to that person's injury. You are trying to create a new layer of skin with your hand, and it's not going to work if you just rest it gently on top. You are fighting their blood to stay back inside their body, and you also, when you apply really good pressure, you're crimping off the ends of those vessels that are damaged. Just like if you've ever gone to a garden hose, right, that's running, and you step on it, and it stops that flow because you have crimped that vessel down to stop the fluid from passing through and exiting the open side of the hose. That's what we're trying to do with veins and arteries. We're trying to crimp them off by applying really good, hard, direct pressure to wherever that bleeding is. And I'd say probably like 70 to 80% of wounds we see on the ambulance can be controlled with direct pressure. But there are going to be some that we can't control with simply direct pressure. Does anyone know what we would do in the event that we can't? Oop, I spoiled it. Anyone want to repeat what you just saw on the screen? Yeah, Zoe, great job. A tourniquet, right? So if a wound is not stopping bleeding after we've applied good direct pressure for like a minute to 2 minutes, if it's continually pouring out around your hand, we can apply what we call a tourniquet. So tourniquets look like this. The ones that we're going to use at GIV look like those down there. Now, they are really kind of simple because what they are is this just a strong piece of nylon with this stick that we call a windlass. So we apply it, we Velcro it down nice and tight, and then we start twisting that windlass until it gets really, really tight around that person's arm or leg. And what that's doing is essentially crimping off the artery that is bleeding, or those veins that are bleeding above where that injury is. So if I'm bleeding really badly from my forearm and the pressure isn't stopping it, I'd put a tourniquet on up here, tighten it down really tight, and now the blood that's trying to come from my heart to my arm is just going to get stopped and then recycled back to my body. I'm essentially just turning off the flow of blood to that injury. So if it can't get past the tourniquet, it won't be able to leave the injury in my arm. Now, tourniquets are great. Yes, Gladys, you picked up on it. Tourniquets work really well, but we can only use them on arms and legs. All right, let's say I'm bleeding really badly from my head and I put a tourniquet on my neck. That's not good, right? Because I'm cutting off the airway and I'm cutting off the blood flow to my brain. That would just be stupid. Let's say I'm bleeding really badly from my abdomen, right? No, it's not going to work there because my arteries are really deep and I have a lot of internal organs and bones in the way, so I couldn't control bleeding on the abdomen or the neck or the head or really anywhere that's not on an arm or leg without a tourniquet. So we do have a way we can help those patients as well, but we need to recognize that tourniquets only work on arms and legs. And the way that I kind of think about this, right, if somebody is bleeding, they're wasting water. Your parents or guardians have probably been upset with you if you've left the water running before because it makes the water bill go up. But you just turn off the faucet, turn off the tap. That will stop that blood from leaving their body. So we're always going to start with direct pressure. Do it for like a minute to 2 minutes. If it's not slowing, then we're going to move up to applying a tourniquet. And if it's in a place that we don't have ability to apply a tourniquet, we do have another step. Jaron, no, not that I'm aware of. So when we can't tourniquet, like in the places where like our upper chest, our lower abdomen, our back, our upper groin, places like that where we can't apply a tourniquet, we have a special kind of gauze called hemostatic gauze, also known as combat gauze. Essentially, it is just normal gauze, like we would wrap any old injury in, but it does contain a chemical that helps blood clot. It essentially forces blood to get thick and sticky and clot. The problem is, we can't just put it on top of a wound, right? We can't just rest it on top and expect the bleeding to stop, because especially in one of these areas, the arteries are deep or the vessels are deep, right? So if we just put the clotting factor on top of it, we are just stopping blood from leaving the body, but we're not actually fixing the vessels that are bleeding, and so that bleeding can continue internally. So we have to do something called wound packing.
Once you've identified a wound, hold pressure, direct pressure, and expose that wound. Go ahead and try to identify the major bleeder or any other bleeds within that wound. We're going to hold pressure on that wound. Open up your combat gauze. Make a small ball. One for one, replace the finger that's holding pressure against the bleed until you've packed that entire cavity. Again, one for one, maintaining pressure while you're packing and ensuring that blood isn't seeping through or around the combat gauze as you're packing it. You're going to continue to pack, maintaining pressure the entire time you're packing. Once you've packed the entire wound, hold pressure over the wound, ensuring that blood isn't seeping around or through the combat gauze. Hold pressure for 3 minutes. Once the 3 minutes is up, and it's time for a pressure dressing.
So that's a little bit more intense, right? When I first learned that we might need to do this, I was like, you want me to do what? Right? You want me to put my fingers inside somebody's open wound, find the vessel that is bleeding, and then start packing it? Well, yeah, that's how we're going to do it, because those vessels are deep, right? And so we're going to essentially try holding pressure with our fingers to start. We are going to feel the flow of blood over our hand or over our finger where it's bleeding from. We're going to try to crimp it off with our finger to start. We're going to get our combat gauze, and we're going to pack it into the wound. We're essentially trying to fill that entire cavity with this gauze because it's going to create that blood to become thick, and it's going to create plugs right at the openings of those arteries or those vessels that are going to essentially stop that bleeding. So we pack it in, we hold direct pressure on top of it, and we let the chemical go to work. So Beatrice, what do you do if there isn't access to hemostatic gauze? We're just going to use normal gauze in that setting. On an ambulance, we always carry a lot of hemostatic gauze just in case, but if you're out in the wilderness somewhere and all you have is normal gauze, it's going to help, but it's not going to be as effective. So you can still pack without hemostat, but hemostat is designed for this, and it just makes it more effective. So use what you can, use what you got. This skill will still translate to non-hemostatic gauze. It will still try to help, but it just won't be as effective. All right. So this is what we use on any bleed that is not stopping with direct pressure in an area that's not on an arm or a leg.
What?
Now, we were talking about internal bleeding as well, because there are situations where somebody might have arterial or venous blood entering and pooling inside their body that we can't see. It can range from, something like this down in somebody's leg, where you can see the discoloration and the swelling, or it could be much more dramatic, where somebody here looks like they sustained a big traumatic injury, and we can see that blood actually pooling underneath their abdomen. All right. This is one of those things that's kind of tricky to assess because it could be quick bleeding or it could be slow. And you might not think about this, but your body actually has a lot of empty space inside of it that blood can pool into. It's not just a solid mass. Places like our abdomen, our pelvis, and our thighs can actually hold a lot of blood before we start to notice that it's swelling or that somebody's internally bleeding. And remember, when we talk about compensation, we're going to talk a little bit more about shock today. The body is really good at keeping somebody normal, keeping them feeling relatively okay compared to normal at first, right? So somebody could be bleeding internally for a good amount of time before they start to show signs and symptoms of them actually bleeding internally, which is why we really have to rely on that suspicion of injury. So somebody got in a car accident going 80 miles an hour. They're complaining of abdominal pain, but they're like, I just think it's because I was wearing my seatbelt kind of high on my abdomen. I'm bruised there from the seatbelt. I feel okay. This actually happened to friends of mine who were responding to a call. A woman got in a fender bender on the highway going like 70 miles an hour. She got out of her car. She was like, I feel okay. I did take quite a big hit, but my neck, my back, all of that feels fine. I just kind of feel a little bit queasy, a little bit uncomfortable in my abdomen. I still want to get checked up at the hospital. And her vital signs were normal. They were fine. Didn't show any signs of shock. Thankfully, the crew convinced her to go up to the hospital with them, because in about 5 minutes, as they started to drive away, she started to show signs of decompensated shock because she was bleeding internally in her abdomen. They got her to the hospital, she got surgery, and it was fixed. But it's one of those things, if you wait too long, if you're not suspicious, somebody could be bleeding internally. So how we can assess for it are things like discoloration. Edema means swelling. And then also rigidity, which means if you touch your arm right now, right, even if you work out a lot, there's probably going to be some squish to it, right? But if I've been bleeding into my arm for a while, it's going to become swollen and it's going to be hard to the touch. Like you're not going to be able to squeeze into that skin as much because there is essentially like a water balloon under there. It's going to become rigid. That skin is going to reach a point where it can't be compressed anymore. So I would wager that if you were to assess or palpate this leg, it would not feel squishy. It would feel pretty warm and rigid to the touch, right? You can also see in this picture that this person's abdomen looks a little bit distended, right? It looks like it's swelling out, and you can see the discoloration of where that blood is pooling, and it makes their abdomen distend out. It's going to be rigid to the touch, all that kind of stuff. So that's going to come back to play when we start doing our head-to-toe trauma assessments, palpating the abdomen, feeling for things like rigidity, feeling for or looking for things like discoloration. Yes, I mean, the main thing is it's also going to be involving the swelling and the rigidity. Like discoloration from a bruise, right? It's going to look similar to this, but a bruise is going to fit the mold of the injury that it had, right? So if you get hit with a baseball, you're likely going to see a bruise forming in the shape of a baseball. That might swell up in that area, which we call like a hematoma, where you get like a welt. But if somebody's bleeding internally, the discoloration might spread, right? It's going to go down with gravity. So if it's on my leg, my blood is going to start pooling down my leg towards my ankle if I'm standing up, because it's just liquid. It's just going to make its way down. So it might be a difference of where somebody was struck versus where you see the discoloration, but it's also going to be based off of the mechanism of injury. If someone is hit with a baseball, I'm not super worried that they have an arterial or internal bleed, right? Bruising is technically a type of internal bleeding, but not really life-threatening. It's just damaged capillaries. So that's a great question, Paige. Now, there are other places that we can bleed internally that aren't just based off of like our thighs or outside of our organs. We can also have internal bleeding inside some of our body systems, like our stomach or our intestines or our lungs, anything like that where that can be damaged. So these medical terms here, these are some of the things that you might see that we call internal bleeding that are like inside of our systems rather than outside of our organs. So ecchymosis, that's just a fancy term for bruising. If you want to break that out at a party and really impress people, that just means a bruise. A hematoma, this is when blood pools under the skin. So if you've ever got like a welt on your head, like you bonked your head really bad and then you start getting that, like an egg forming, that's a hematoma. That's just blood kind of pooling underneath the skin, and it will eventually just recirculate. It'll fix itself. It doesn't really mean somebody's going to die, but it could just be that blood is pooling underneath that skin based off of that traumatic injury. Now, when we start seeing things like inside of our systems, hematoemesis, this means somebody is vomiting blood, meaning that they probably have blood in their stomach or in their airway or in their esophagus. So when they vomit, you'll see some red tinge to it, or you'll see just straight up blood. Now on the other end, literally, we've got things called hematochezia. Somebody pooping red blood. That is not a good thing, right? People can have wounds or things like that in their intestines, and it's really hard to control that bleeding. It's kind of hard to notice it as well. So that's what we'll see. Now, the difference here, melena is also an evidence of internal bleeding in somebody's digestive system, but it helps determine where. So if you see red bloody stool, somebody is passing red blood, it is likely that they are bleeding from somewhere lower in their intestines, right? Underneath their stomach, because it's not being digested. It is just red blood. Hematochezia is bloody poop. What causes it? Could be a whole bunch of different things. Could be a physical injury. It could be an ulcer. It could be after like trauma. There's a whole bunch of different things. It's not entirely common, but can be caused by a lot of different things. Now, melena, this is blood that has been digested. So it's black and tarry. It kind of looks like coffee grounds, right? This tells me that somebody is bleeding higher up in their digestive system, because that blood is actually getting processed by the body. It's being digested, and that's what digested blood looks like. All right, so if you respond to somebody and there is red blood in their toilet, you can essentially estimate that they are bleeding from somewhere lower in their intestinal system because the blood is not being digested, versus if somebody is passing a black, tarry, coffee ground looking stuff, it's likely that that blood is higher up in their system, either in their stomach or just below it, because it is now being digested. All right, gross to think about, but it's also a major concern for us because we can't stop it, right? We need to get them to the hospital. They might, yeah, Gladys, they might feel pain. Most of the time, though, Not really, right? It's one of those things where somebody might have like an abdominal discomfort, but it kind of might feel like normal cramping or just like indigestion. Honestly, the times that I've seen this, it's people being like, yeah, I have some abdominal pain. I've been going to the bathroom a lot. Like, I don't know what's going on. I feel tired. I feel weak. And then I ask him, like, okay, is everything coming out normally? And they're like, well, my poop has been kind of black. And I'm like, oh boy, I think you were bleeding, right, in your stomach. So let's get going. The problem with this is that a lot of people might not recognize it's an emergency until it's too late, because they just might think that they're having some weird indigestion or that they ate beets, right? But it's one of those things that as soon as we see any sort of blood coming out of somebody's, rectum, if it's red or if it's black, we really want to get them to the hospital because they're likely going to need surgery. Okay, so let's talk a little bit about car accidents. Some of the more common injuries that we see in these situations are head, neck, and back injuries. So damage to somebody's head, to their spine, or to the spine lower in their back. This is due to usually to like whiplash, right? If somebody is struck from like the rear, they're going to go back and then forward. Whereas if they hit somebody going fast, they're going to go forward and then back. And that can cause those neck, head, and back injuries. If you're not wearing a seatbelt, you can go forward into the windshield, right? Slam your head on the windshield. That can cause it. You can slam your head on the steering wheel. If you're not wearing a seatbelt, you can get thrown around the vehicle, and that can cause a lot of other injuries. We also see a lot of chest injuries in these situations, ranging from like mild, because a seatbelt, it does stop you from bouncing around the car, but it does catch you, right? So a lot of times people have bruising or pain across their chest in line with where their seatbelt is. But again, if they're not wearing a seatbelt and they're thrown forward, steering wheels can damage the chest. If someone's thrown into them, they can have broken ribs. They can have all that kind of stuff. We also pretty frequently see arm and leg injuries, just based off of usually how people are sitting. Also, if you're like bracing against the steering wheel, right, and you crash into something, you're likely going to hurt your wrist, your forearm, or your elbow. Now, I don't know if you guys do this if you're sitting in the passenger seat, but never, never, never put your feet up on the dash, because you are basically asking to become a flamingo, have your legs bend the wrong way. That is a very common thing that happens if people are in the passenger seat and they get into a car crash, they break their legs, okay? Not very good. Don't do it. And then unfortunately, the other thing we see kind of frequently with high-speed car accidents is internal bleeding, because even though the seatbelt is going to stop you from getting flung around, if you're going 80, 90 miles an hour, that is also a potential to cause internal bleeding. That's why you want to sit with your seatbelt around your lap, not around your stomach, because if you go forward, that seatbelt is going to press into your abdomen. It can damage your arteries, it can damage your spleen, it can cause internal injuries like that. Now, the other thing we need to talk about is something called croup and contra croup. So it's actually kind of interesting, but your brain is pretty much floating in your head. It's suspended in fluid, and your brain is mostly just gelatin. It's made up of fat, essentially. So we tend to see injuries, or where people respond to say that they have pain in their head after a head injury, opposite to where they get their impact. So you can see in this image down here, the force is starting at the front, but the brain actually picks up the most amount of speed on its way back, right? It whiplashes to the back of the head. So if you get struck in the front of your head, people tend to report that they have pain in the back. And if people get struck in the back of the head, they tend to report pain in the front, because that's where their brain kind of whiplashes and damages itself against the skull. So don't be surprised. Like if you find somebody who got struck in the forehead with a baseball bat, that they're complaining of pain in the back of their head, or vice versa. So it's not something going wrong. It's just one of those kind of counterintuitive assessment things that we find. Now, we do have another acronym that helps us keep in mind what type of injuries we are looking for. It's called DCAP BTLS. And essentially, these are the biggest amount of, or most of the injuries that we can find when we're looking for or doing a trauma assessment. So when we're doing those head-to-toe assessments, this DCAT BTLS should be in our brain because we're trying to essentially find any of these injuries. Now, just so you know, this is where I do start showing some pictures, okay? So a deformity, that is just a straight up, that does not look right, right? A symmetrical issue. Humans are mostly symmetrical, right? So if you find somebody laying on their back and you notice something as dramatic as that, that is a big sign that that is probably broken. Now, this guy, it looks like he had an injury that was not correctly healed. He broke his femur at one point and then he didn't get appropriate treatment. So this doesn't look directly after an injury, but it's a pretty good example of, okay, that leg looks relatively normal. That one's at a bad angle, right? That is a broken leg. Very easy to see that extremity is broken. Contusions, this is another word for bruise. So ecchymosis is the active, like describing bruise, but a contusion is just any sort of like discoloration that we see. So this is also a sign of like a broken bone underneath. If it's not just straight up deformed or easily recognizable as a fracture, a large bruise on an area like this can help us have suspicion that that bone is fractured, but it might not be like deformed, right? Now, A stands for two things. It's an abrasion. Abrasions are essentially like rug burns, right? If you remember being a kid, like running around on your hands and knees, and then you scrape the skin off of your knees, and it's just like really painful. That is a contusion. Or sorry, an abrasion, my bad. So we see this a lot like with bike accidents or motorcycle accidents, somebody being skidded, like they fall off and they are dragged along the ground, pavement, road burn. These are very painful, right? And it's essentially like taking the top layer of skin off of somebody. So now the next one, avulsion. Again, disclaimer, this one is pretty gross. An avulsion is when the layers of skin are essentially sliced but still attached to the body. Okay, that would be an avulsion. So this can happen for a multitude of different reasons. It could be like a knife. It could be just a bad timing, somebody getting cut with something. One of the times I've seen this on real calls for me was actually due to like a walking cane. An elderly lady had like one of those aluminum change the size walking canes, and there's that little lip where the metal isn't like so smooth. She was trying to walk and she slipped and fell and she pulled her walking cane along her leg, and that just happened to cause an avulsion. So we showed up, she had a large open wound and a flap of skin hanging off to the side. So in this case, essentially bleeding control is what the best we're going to do. We're not going to essentially touch or move that skin. We can just do direct bleeding control, and then we'll let the hospital worry about fixing it. Puncture. This is anything entering the body. So if maybe we see an object still in somebody, or we just see a small hole that is bleeding, or a large hole could potentially be there as well, depending on the size of the object that penetrated them. A burn, right? Anything that could be caused by electricity, it could be caused by fire or thermal heat, and it could also be caused by chemicals. We are going to break down and talk about burns a little bit more today. Now, tenderness, like the lame one on the list here, this is just the person reporting that there is pain. So if you touch an area, right, you're doing an assessment on somebody, you don't necessarily see a bruising, but you touch an area and they go, ow, right? Oh yeah, that hurts. That is just our sign to say there might be an injury there because they reacted in pain when we palpated it. A laceration, this is just a cut. It could be smooth or jagged. It could be deep or shallow, but anything that slices through the skin and gets down into the layers. So typically there's going to be some bleeding, but there might not be. And it's really caused by something sharp, whether intentionally or not. That's just going to be a big thing for us to treat with direct pressure. And then again, the hospital will likely do stitches depending on what's going on. And then swelling is another big part of this assessment. And the easiest way to define or look at swelling is because humans are symmetrical, right? You can see that this leg is swollen based off of how the non-swollen leg looks. It looks red, it looks hot to the touch, it looks rigid, right? Whereas you can see kind of more the definition of this normal person's legs, whereas in this one, you see that it's a little bit more bulbous, right? So those are all the things that we are looking for when we're doing our trauma assessments. Any of these basically tell us that there is an injury on the body. And we just want to make a note of what injuries we see, right? Because we might be able to treat some of them, and otherwise we just want to know what's going on so that we can tell the hospital so they know where the injuries are as well. So burns, right? Like I was saying, burns directly relate to the layers of skin. So we've got the epidermis, the dermis, and the subcutaneous tissue. So when we define like first or second or third degree burns, we're talking about what layer of skin it affects. So a first degree burn, you probably have had multiple first degree burns in your life. This is like a sunburn, right? Or if you touch something too hot and you pulled your hand away really quickly and then you had that like painful kind of red spot on your finger or wherever for a good length of time. These are not super life-threatening, right? If you had a really bad sunburn, the treatment is apply aloe vera, stay out of the sun, and drink lots of water. It's going to be painful. It's going to be itchy for a little bit, but you're not likely going to die. Now, once we get past that epidermis, right, the epidermis is built to protect us. So if we are just damaging the epidermis, the body's probably going to be okay to heal it. But if we start getting down into the dermis past our external layer of skin, that's where these burns can start to be more life-threatening because it opens up essentially ways for bacteria and viruses to get into a body to become infected. So secondary burns go through the top layer and into the second layer. We tend to see what we call blebs or blisters forming. It's going to be like a yellow kind of blister, does not look normal. These are also very painful because essentially the dermis underneath that epidermis has started to like liquefy, it got damaged, and it's really, really painful. Anything that gets past that into the subcutaneous tissue or down into the muscles, really anything below the dermis, is considered a third degree burn. Now, this also is exemplified by charred skin. Like if you see things that are like black and burned and looks like, burnt meat, that is also a big deal because that just means that the skin has like received so much energy that it's just killed, that it's just damaged, right? The other thing about third degree burns is that you typically see what we call like not necessarily a direct bullseye, but in the spot where the most amount of heat was, you'll see third degree burns. And then as you move away from that area, you'll see second degree, and the further away from that, you'll see first. So pretty much anybody who has a third degree burn also has a second and first degree, which adds to the pain. Because honestly, if we're talking about third degree burns, a lot of times the nerve endings are actually completely damaged, burned away. So people aren't typically feeling the direct pain from that third degree burn. They are just feeling second and first degree pain around it. So still not good, right? So again, here are some pictures. First degree burn here, right? This is just a really bad sunburn. You can see just like a little bit of a blister forming, but it does not look anything like those blebs. Blisters are different than blebs. So for this person, it's probably going to be like an annoying couple weeks. The skin is going to peel. It's going to be itchy. It's not going to be pleasant to touch, but they're not likely going to need to go to the hospital for any sort of treatment. Whereas over here, you can see these blebs forming. Now, I have this image covered for a little bit because that's me. That's me with second degree burns on my shoulders, right? Those what blebs look like, and this is just one shoulder, but you don't see that it goes all the way across my back onto the other shoulder. This was just after 2 days of like being at a beach house. I applied sunscreen every day. I thought I did it enough, but I was also swimming a bunch. I was in and out of the water. I was sunbathing, whatever it was. I woke up on Sunday morning with second degree burns on my shoulders. Some of the most pain I've ever been in because these really, really hurt. Okay. And also you can see that there are first degree burns around it, but these are what we call blebs. And these become dangerous because if they are ruptured or if they're popped, they essentially leave an open passageway for bacteria and other gross things to get underneath the skin, which can lead to really severe infections. And because the skin is damaged like this, it's not as able to fight off infections as it would be without it. So take this from me, wear your sunscreen. You do not want second degree burns on your shoulders. Now, again, you can see this picture here with this person with really severe third degree burns. You can see that charring right, of the skin getting down into that third layer to the subcutaneous tissue. But you can also see the areas of second degree and then first degree burns around it. So they're likely not feeling pain directly from the burnt, charred skin. They're mostly feeling pain from that second degree burn and that first degree burn around it. It's incredibly painful to have this layer or this extensive amount of burns. All right. We also just want to know how deep those burns are, right? That's why we also call them superficial, partial thickness, and full thickness, because first, second, and third degree doesn't necessarily encompass everything, because that's just about epidermis, dermis, and then subcutaneous. It can get lower into like the muscles, even down to bone, depending on the situation. So while we still do use the terms first, second, and third degree, most of the time now we're going to be using superficial, partial thickness, and full thickness as our descriptions for what types of burns somebody experiences. Now, another big part of determining how bad burns are is how extensive across somebody's body they are. We essentially want to try to estimate what percentage of somebody's body surface area was damaged by these burns. And to do that, we just have what we call the rule of nines, which is just a kind of quick, easy way to estimate, depending on where the person was burned, how much of their body was burned. So the front of somebody's chest is 9%, the back is 9%, the abdomen is 9%, the back of the abdomen is 9%, the front of a leg is 9%, the back of a leg is 9%, a total arm is 9%, the total head is 9%. So it's just a little bit easier way to think about it. It is still kind of confusing. So the idea here is somebody got their entire right arm burned with third degree burns, right? It would be easy for me to say they have about 9% coverage of third degree burns on their entire body. Their entire right arm is covered in third degree burns when I'm giving a report up to the hospital. That's just going to help them have a better understanding of how severe this person's injuries are. The more percentage of somebody's body covered in burns, the more likelihood they are to suffer from other issues. Most of the time, burns don't actually, or the act of being burned doesn't actually lead to somebody's death. Burns wreak havoc on the body's ability to fight off infection and also maintain body temperature. So if somebody suffers widespread burns, they are likely going to have a tough time in recovery because they need to be fighting off infections constantly and their skin is no longer able to do that. So a lot of people die from burns in the hospital afterwards from infections. Now, another way that we can kind of estimate somebody's extent of their burns is by something called the rule of the palm. So if you take the patient's palm, excluding their fingers and their thumb, just that amount of skin, that is roughly 1% of their body surface area. So if it's like spread out, like they have a burn here, they have a burn on their back, they have a burn on their leg, and it's not as easy to just use the rule of nines, you can use their palm and essentially estimate the percentage. So if I did this, 1%, 2%, that's about 3% of my body surface area covered with burns based off of the size of my hand, the patient's hand, right? Not yours, but the patient's size. So that's just kind of an easy way to do it. Now, how we treat them is also going to be important. One of the biggest things we want to do is make sure that we don't expose them to dirty things, right? So if they're covered in burns and they're rolling around in the dirt, that's not good. So mainly what we want to do is use what we call a sterile burn dressing. They're big sheets that we have in the ambulance that are kept in pristine, sterile conditions, like in the package. So when we open it, we want to be using gloves and we want to make sure that they're relatively clean, and then we can put that bandage on, essentially wrap them up in this to help them essentially keep dirty stuff outside of their injuries. First degree burns, though, we don't really need burn sheets. Depending on the extent, if somebody's got like 70% of their body covered in first degree burns, I would recommend they go to the hospital just to make sure. But this is going to be like, stay out of the sun, apply ointment, like they're gonna have to deal with it. They're gonna heal slowly. Whereas if we start to see the partial thickness going down into their skin, don't pop those blisters. That's the only thing keeping infections out, essentially, cover it with a sterile burn dressing. And then 3rd degree, this is another one of those things we want to get going. So we're going to cover them with that sterile burn dressing, keep them nice and warm. Why is it so imperative that we keep patients who suffered burns warm? Why do you think? Yeah, Evie, exactly. Nice work. It's because the skin, right, the largest organ in our body, regulates our body temperature. It knows what the outside temperature is, and it increases our ability to get warmer or get colder depending on what's going on. So if somebody has a lot of burns across their body, they can suffer from hypothermia. They can get way too cold because, one, they don't have that insulating layer anymore. They're losing heat, but also their body has lost a lot of its ability to actually determine what temperature it is outside. So they can go into what we call hypothermia. So we want to keep them nice and warm. Is medication the only way to manage fluid loss in cases of 3rd degree burns? Medication, I mean, what I would do in this situation is, as an advanced EMT, if I think somebody is suffering from hypovolemic shock where they've lost fluid, is I would do an IV and give them saline, right? So I guess kind of yes. Really the only way to increase the amount of fluid in somebody's body is to have them drink, or we put it in for them. Can VEFRs use antibiotic ointments for burns or other cuts? No, we don't really do that on the ambulance, right? Our job on the ambulance is to stop bleeding and get people to the hospital. Antibiotic ointments and things are really saved for the doctors because we don't know if it's a bacteria. We don't know if that's going to help or make it worse. So we don't really carry antibiotic ointment on the ambulance. That's going to be like a secondary care kind of thing. You in your personal life can absolutely use antibiotic ointment on a cut, but not on the ambulance. We don't really do that. Okay, that's burns. Does anyone have any more questions about burns? Cool. So I do just want to talk about altered mental status after trauma. So we talked about AMS yesterday, but some of the things that we can see after someone takes a bonk to the head is concussions and confusion. Now, I want to be very clear. It is not within any EMT or paramedic scope of practice to diagnose a concussion. A true concussion diagnosis takes actually probably a few days, right? Somebody needs to have an initial assessment, and then they need to go back and have a secondary assessment. We are not trained to do so. However, we can recognize signs of a concussion and really urge that somebody go get checked out and actually be diagnosed. So we can say, you know what, it's a possibility that you have a concussion, but if you say you 100% sure have a concussion, you're lying, okay? Because we do not know how to diagnose them, and we can't do it in the short amount of time that we see somebody on an ambulance. Concussions are also very common. You do not have to get hit in the head to have a concussion. You also do not need to essentially be knocked unconscious to have a concussion. People have had concussions from falls, right? Because of how that coup and contra coup works. If I fall down, my brain can hit the side of my skull and it can be bruised. That's essentially what a concussion is a minor damage to the brain. So things that we can recognize, things that we can recognize here are things like brain fog, confusion, like general inability to focus. So if someone just sustained like a big hit to the head and they're like, oh, like what were we talking about? Like weren't I just over there? Oh man, like I can't think straight, right? That's a sign of a concussion. Other things are going to be like they feel nauseous or they vomit after a strike to the head. Photosensitivity is essentially where lights are really blinding and it hurts their eyes. Same thing is hyperoxis, but noises are really loud and just like extra loud and it hurts them to hear loud noises. They can have a headache or like pressure in their head. They can be dizzy and they can be kind of lethargic, like sleepy. We actually don't want somebody who just got a big knock to the head to go to sleep because that's a big sign that something bad is happening, right? Now, our treatment is kind of interesting. We're still really working on the best way to treat a concussion. I remember in high school, there was all this talk about concussions, and the treatment back then was you have to stay in a dark room for as many weeks as it takes with sunglasses on. You can't read, you can't look at a computer screen, you can't do anything. You just have to sit there in the dark. And then a few years later, some studies came out that was like, actually, you want to exercise, you want to read, you want to like do everything opposite of what we just said. And then more studies came out that was like, actually, it's dependent on the person, depends on the type of concussion. It's really, there's no one way to treat it. So mainly for us, we just want to minimize any uncomfortable situation or symptoms that they have. So if they're having photosensitivity, we want to keep them in a dark ambulance. If the sounds are too loud, we want to limit the amount of sounds. Other than that, we just want to bring them to the hospital so that they can be diagnosed. Yes, Owen, concussions cause lasting damage to the brain. The more concussions you have, the more damage it is. So, if you're a football player, right, helmets do not actually stop concussions because your brain is in liquid. It stops physical injuries, but it doesn't stop your brain from bouncing around. So one of the biggest causes of long-term concussions has been American football because people think they're invincible with those pads on and they slam their head into other people and they get concussions. If you want to watch a really good movie, there's a movie called Concussion, right? And it stars Will Smith, and it's talking about how the idea and us learning about concussions has changed, because I wanted to show you this picture. This is a normal brain, right? And this is a brain of somebody who has sustained like concussions and was not treated over their lifetime. Okay? It causes something called advanced CTE, chronic traumatic encephalopathy. Encephalopathy. It's a hard word to say. But if you are getting repeatedly bonked in the head and you are not letting your brain heal, your brain starts to become incredibly damaged. If you've heard any stories about, like old-time football players slowly starting to have more and more issues in their 40s and their 50s, causing them to be like aggressive or make really poor decisions, or just in general like developing Parkinson's-like symptoms and things like that. That's because of advanced CTE, because they would get a concussion, they would keep playing, they would continue to bang their head, they would not take a rest, they would not get treatment, and they're developing essentially just traumatic brain injuries. So this is just an alert for you, right? Results from repeated concussions that are not allowed to heal. And concussions can take weeks to years to heal. Some people continually feel signs of a concussion for years afterwards. Now, this presents with like an onset of confusion, like impulse control goes away because their brain is starting to degrade. They can be aggressive. There have been a lot of cases that have been tied back to CTE of people with like professional footballers and things like that having violent outbursts or, committing crimes because their brain is starting to degrade. We see early onset of dementia and Parkinson's disease and things like that. So essentially, if you are a physical sport person, if you get bonked in the head, if you get diagnosed with a concussion, it is within your best interest to take a break and let your concussion heal. All right. I was a rugby player in high school. I definitely got hit in the head a few times, and it was a huge deal. If we got bonked in the head, they took us off the field and they're like, go see the physical trainer, make sure you don't have a concussion, and you're not getting back on the field until this happens. My sister also played rugby, and she got a really, really bad concussion, and my parents wouldn't let her play until she was healed. And then when she went back, they made her wear one of those scrum caps, even though she wasn't in the scrum, just like the biggest helmet that we have in rugby. But the main thing is, right, we don't hit with our heads. We wrap with our arms. So be very careful. Wear helmets if you do any sort of sport like that. If you ride a bike, if you do skateboarding, rollerblading, whatever it is, concussions can be really severe. All right. Your brain is all you have. Don't let it degrade inside your skull. So there are other types of what we call traumatic brain injuries. Somebody can have a concussion, but it can also be worse. If someone gets slammed really hard in the head, they can just have direct damage to their brain. So signs of this are just in general confusion, somebody being altered after getting hit in the head, not knowing their name, not knowing where they are at the moment, not really knowing what's going on. That is a bad sign that their brain might be damaged. We also see amnesia sometimes, where oftentimes we call it fishbowl amnesia after somebody gets struck in the head. And the example I have of this is I went to a call in Winooski where a guy was struck by a car. He was walking across the street in a crosswalk and somebody bonked him, right? He hit his head really hard on the pavement. We picked him up. We were transporting him. He was awake, but he was really confused. When we were still on the road and we were treating him, he looked at me and said, "Hey man, what happened?" And I said, "Hey, you got hit by a car. Okay, we're going to take good care of you. We're bringing you to the hospital." And he goes, "Oh, okay, thank you." In the ambulance, about 5 minutes later, he grabs me by the collar and says, "Dude, what happened to me?" I said, "You got hit by a car." And he goes, "Again?" And I was like, "No, dude, same car. We're still in the ambulance. We're bringing you to the hospital." Another 5 minutes later, we're almost there. He grabs him by the collar and says, "Man, what happened to me? You got to tell me." And I said, "You got hit by a car." And he goes, "Again?" And I said, "No, dude, same car," right? But it's just how that kind of works. Like the brain is damaged, so that's not a good sign, right? It can also lead to bleeding inside the brain. Similar to like how a stroke can be due to bleeding inside the brain, it's very similar. Like pressure starts to build up, blood is starting to pool in the brain, causing people not to be able to use all of their brain, and the brain tissue does not get enough oxygen because it's being squished. So we always transport people with potential traumatic brain injuries with cervical spine protection, and we want to make sure that we're calling for additional help like an advanced EMT or a paramedic if we can, and we want to get them to the hospital very quickly. We don't mess around with the brain, right? The brain controls all of our autonomic functions. If the brain is done, that person is done. So any sort of damage to the head is a big deal. All right, it could be something like this, right? Someone takes a big strike to the head and that blood starts to pool. It starts to compress on our brain, limiting the amount of things that we can do and eventually leading towards death. So protect your heads, everybody. Okay. Here are different types of musculoskeletal injuries. So things affecting the muscles and the bones. There's also going to be some gross pictures coming up in the next few slides. Okay. So a fracture. This is what we call a broken bone. It can range from like small hairline fractures that are just cracks in the bone to full straight up it is snapped and the arm is like bent in half in the middle here where it's not supposed to. Okay, so that's what we'd call a fracture. A dislocation is a disruption of a joint. So a shoulder, an elbow, a wrist, a hip, a knee, an ankle, all those joints that we have in our body. This is like the parts of it that are supposed to stay together slip out, right? That can also cause damage to like arteries and also ligaments and muscles. Like muscles and ligaments can be torn as well, but usually it doesn't involve like a broken bone. It's just that the joint, like the most common type is a shoulder dislocation where the ball of your humerus just slips out of its socket, and it's painful, uncomfortable, and oftentimes they aren't able to move that arm. Now a sprain, this is a joint injury where ligaments are torn. So if you've ever sprained your ankle, it's like you roll it and you get a lot of pain. That would be a sprain because it's your ankle. It's a joint, right? Whereas a strain is a muscle. So if you've ever overworked and like pulled your bicep or something like that and it hurts, that would be a strain because it's damaging to the muscle, not necessarily due to a joint, right? So we oftentimes hear people complain of sprained ankles because they roll it, whereas a strained muscle is you're working too hard. Maybe you try to pick up something too heavy, you force yourself to do it, and you can damage that muscle. Here we go. Okay, so signs of fractures. It can be very obvious. It can be things like bones sticking out of somebody's arm or their leg. Honestly, it's pretty rare that the bone stays sticking out unless in very dramatic situations. Most of the time, we see what we call like open fractures, where somebody has a clear deformity. We also see like an open wound, right? But the bone isn't just like straight up sticking out like it does in the movies. It can happen, but it's less common. Most of the time, if we see an open fracture, the bone kind of does this. It goes out and then goes back in. And so we might see like a cut that's bleeding over a deformity, which tells us that that bone exited and caused that damage. You also just might see straight up like deformity, right? Something that is clearly broken, right? That hand is not supposed to be there. You can see the bones sticking out, essentially, not through the skin, but a clear deformity. Now, there are other ways to tell, like it's not always going to be that dramatic. Tenderness and guarding are also big ones, right? So if somebody is like holding their arm and you go to assess it and they just like instinctually like move away, that tells us that they're in a lot of pain and they don't want you to touch it. That can signify that there is a broken bone under there. Swelling and bruising are also big ones. Like I was saying before, like your body has some backup systems. So if you break a bone, your body starts to swell that area, trying to essentially make like a cast, right? It just makes it harder for that body to move in that area. It's not great. It doesn't feel good, but it does try to limit some of the movement of that broken bone. And then bruising is also another one. Now, crepitus. This is a fancy term that essentially means the sound of bones rubbing against bones. So if for some reason you're like palpating an arm and you feel it be squishy and there's like creaking, and if you've ever like made pasta, right, and you do the American thing where you take the spaghetti, you break it in half. Next time you do that, before you drop it into the pot, just rub those two broken ends against each other. It's going to kind of be squeaky, crunchy. That's what crepitus sounds like. It's bones rubbing against bones. It's really not good. Does the bone ever break off when it punctures through the skin? I wouldn't be surprised if that has happened. Bones can like shatter and stuff like that. It would take a large mechanism of injury for that to happen. I have never seen it happen, but I wouldn't be surprised if it did. I had an injury where I completely tore a tendon in my ankle and had to get surgery. Would that still be under the category of sprain? Yeah, because it is a tearing or damage to the muscle. It's just a very severe sprain. After that, we kind of just call it what it is, a torn ligament. Okay, but let's talk about some dislocations, right? So most commonly, I was talking about that shoulder dislocation. Oops, I'm in the way here. So you're going to see that extremity essentially be a little bit longer than the other one. It's also probably not that they're going to be able to like lift it or move it. There is a potential that that dislocation causes the blood flow to be blocked to that extremity. Like if the ball of the humerus slips out and it's putting pressure on the artery, it could be that they're not getting any circulation to that arm, which is not good. That just means it's a really bad dislocation. Now, there are relatively easy ways to fix dislocations. We are not allowed to do that. What we can do is assess and splint, right? We can essentially help make that injury not get any worse, or just make it feel a little bit better while we get them to the hospital where it can be fixed. So we are going to be doing that at the Institute. We're going to be talking about splinting and things like that as well. Moving on a little bit from broken bones, we have here is a pneumothorax. This is when air builds up in somebody's chest and it starts to collapse their lung, making it so that they cannot breathe very easily. This can be caused by quite a few things. It can be caused by an infection. It can be caused by blunt trauma. Also, sorry guys, literally the guys in here, there is a thing called spontaneous pneumothoraxes that mostly affect teenage boys because they typically grow too fast sometimes for their body. If you are tall and you're lanky like me, there's a chance that you could have a spontaneous pneumo. It's just one of the things that happens. When I worked at a high school, there was a kid playing basketball. He caught a pass, turned really quickly, and everyone in the auditorium heard like a pop. And he was like, ow, and he started having difficulty breathing, and they brought him to the hospital, and it turned out he had a collapsed lung because it essentially pulled away from the side of his chest because the ligaments were a little bit behind in growth. So this is dangerous because somebody's lung essentially starts to get smaller and smaller as the pressure builds up in their chest. They're not able to breathe as well, and they're going to have pain on that side. They're going to have difficulty breathing and diminished lung sounds, right? We wouldn't be able to hear their breathing in that side. We cannot fix this. A paramedic could potentially, depending on how bad the situation is. So make sure that you're calling for EMTs who can give oxygen and who can ventilate the patient. That's one of those things. But like an open wound to the chest, like a puncture into the area of the lung, if you look at that wound and you see like bubbling blood or you hear air moving into it when they take a breath, that's a sign that they are developing what we call a pneumothorax. It can also build up so much pressure that that lung completely deflates. We can actually even see their trachea start to move over to one side, opposite of where their injury is, and that just really means it is a bad, bad injury. Now, paramedics, they have a skill called needle decompressions, where in the right circumstance, they can take a long needle with a valve at the end. They can poke it into the chest, open the valve, and let out the extra pressure. And that person honestly feels almost instantaneously better. It's really interesting. Like you put it in, you open it, and you hear air leave. They close the valve, and that person goes because their lung has gone back to expanding to its normal size. So in the event that you're suspecting of a pneumothorax, make sure you are calling for a paramedic because they could probably fix it, whereas we can't. Eye injuries, right? Not great. There's going to be a range of things too. They could just be like a direct blunt trauma to the eye. There could be like a particle in there, like some glass or dust or dirt. We can rinse eyes with saline or sterile water. You know, if you've ever been into your high school's like science classroom, they always have those emergency eye wash stations. That's kind of the same thing that we would do. If somebody had a big particle in their eye and I respond to a high school, that's where I'm bringing them. I want to bring them to the eye wash station to try to get it out. Whereas if there's an impaled object, that's not good. I would never want that to happen, but we're not going to remove it. That's one of the things that we're going to talk about too. If you ever show up and you find somebody impaled by an object, do not remove that object because it's honestly going to make that situation worse. So what we do in this situation is we're actually going to immobilize that object. We want to keep it where it is so that it doesn't move around and cause more damage. Now, the other thing about eyes is that they are connected, right? When I look one way, both eyes go that way. So I'm going to cover the injured eye. I'm going to try to immobilize that object, but that person is still going to want to look around with their exposed eye, which is going to make that eye who's damaged move. So we're actually going to cover both eyes so that they're less likely to want to look around. This is kind of disconcerting for them, but it's one of those things where if they continue to look around, they can make that a lot worse. They could completely damage their eye in that case. So we want to be careful with that. Now, this is the last thing I think we're going to cover before we go on break. How we are going to assess how bad a physical injury is by evaluating what we call the neurovascular function, also known as like the CMSs or the PCSMTs. Because what we're going to check, if somebody has a broken arm, I want to check their distal pulse. Because if I can feel it, right, that means the injury is not affecting the blood flow down to their hand. I also want to check that cap refill to double check. I want to see if they can feel me touching them, if they can move their hands or their toes. And I also want to see what the temperature of their arm is. If it's cold, that's not good. But if it's nice and warm, that means circulation is still happening. We do this before we apply a splint and then also after, right? That's going to help us determine if the injury is getting worse or maybe if we messed up in applying our splints. If we see open wounds, we have to stop the bleeding first, right? I'll go back if you guys didn't get this. But if somebody is bleeding after a fracture, we have to stop that bleeding first because the fracture isn't going to kill them, but bleeding or uncontrolled bleeding could. So we stop the bleeding and then we go on to apply the appropriate splint. After checking the PCSMTs, we can apply cold packs if there's swelling. Like we do have ice packs in the ambulance, and we want to get them to the hospital so that they can get whatever they need, right? Here are some splints. This is what we're going to practice with at GIV, the one that I'm in the way of. These are called SAM splints. This is what we're going to use. And on an ambulance, typically we carry these, which are called vacuum splints. But you can also see that there's just a wide range. All of them are designed to essentially limit the motion of somebody's arm or leg or whatever is injured to stop it from getting worse. And if you're in the middle of nowhere, all you need is essentially a solid stick and some cloth to apply it. Really, once I teach you in GIV the rules of thumb and what you need to consider when you are splinting, you can use anything that's rigid to be able to do it. Was this the slide you're looking for, Aubrey? That's the goal, is just to minimize the movement. Because if someone has a broken arm and they're moving it around, those bones are moving even more inside, causing more damage, causing more pain. Okay? So, general rule, if there is a bone that's broken, we want to immobilize the joint above and below. So if my radius and ulna are broken, I need to immobilize the elbow and I need to immobilize the wrist, because those two bones are connected to those areas, and if those areas can move, those bones can move. Whereas if it's a joint, like an elbow is broken, I want to immobilize the bones above and below, like the humerus or the radius and ulna, because those are what are connected. We're going to check the PCSMTs before and then after, and then we have some splints that we can apply. Now, we can apply a thing like a sling as well to keep the arm up. That helps immobilize the shoulder and the elbow. And then one of those physical splints that we have, like a SAM splint, will physically immobilize the bone itself. So like a sling and swath like this. This is all stuff I'm going to teach you at the Institute. It's harder to teach about it without being able to demonstrate. But essentially, we're going to learn how to immobilize those injuries, how to create a sling and a swath if you don't just have one. These are great for shoulder fractures, clavicle fractures, and humerus fractures. Okay, let's take a break. I went about 5 minutes over, so let's come back at 12:50. All right, I will see you then. So we were just about to start talking about shock a little bit more in depth than we have before. Now remember, media doesn't portray this very well. It's not about being shocked in a sense of being alarmed or upset or traumatized by a situation. This is a life-threatening condition that we call hypoperfusion, because the body is not able to circulate blood, and eventually that person will die. So it can be caused by quite a few different things. It can be caused by like a medical issue, like a heart attack, an infection, anything along those lines. But it can also be caused by trauma. And in the most times we think about trauma, we're thinking about like a physical injury or bleeding, right? Again, somebody's body is going to be able to do what we call compensate, so that after their injury, their body is going to keep them at a relatively normal set of vital signs, relatively feeling normal, not to the point of feeling like okay, but you're not going to notice signs like low blood pressure or anything like that. It can kind of trick us. So that's why recognizing the signs and symptoms is key, but mostly we want to be suspicious, right? Looking at the mechanism of injury. If it looks like somebody could have gotten really hurt and you see somebody walking away from it, I'm going to be suspicious that that person is probably compensating, right? So that's what we're going to try to break down. So there can be quite a few different reasons. It can be broken down into these three, where it's really a problem with the heart. Like it can be a heart attack. It can be trauma to the heart. It could also be issues like obstructive things, like a clot forming in the lungs, stuff like that. So it could also be caused by low fluid volume. So somebody has bled quite a bit. They have a burn, right? Or it could be due to like not being hydrated. If somebody is vomiting and having diarrhea consistently, they're losing all the fluid in their body, and eventually if they don't have enough, there's going to be hypoperfusion. It can also be caused by an issue with the vessels, like the blood vessels themselves. So it can be an infection, a drug overdose, a spinal cord injury, or even an anaphylactic reaction, because the fluid in the body is not, or the vessels are not functioning properly. So when we break it down into these three, it's either a pump problem, a fluid problem, or a vessel problem, right? But it can expand into more things like this, right? Shock itself is in there, but there are quite a few different reasons why. So really there are 5 different categories. There's hypovolemic, which means there's not enough blood volume. So it can be caused by bleeding or losing fluid like in a burn. Distributive, which is like septic shock or anaphylactic, where somebody has a large, widespread infection or their body is responding to an allergic reaction. Obstructive shock is essentially from anything that is blocking the heart's ability to function. So like a pneumothorax, like we were just talking about. If it gets too high up there, too much pressure, that pressure can move over and start compressing on the heart. It can be just from a heart problem, like a heart attack, heart failure, anything like that. And there's also some like metabolic or respiratory issues where somebody is not getting enough oxygen, which can cause shock. So in general, there's just a large range of things that can cause someone to go into shock. It's not necessarily our first priority to recognize what is doing it, but we want to be suspicious that if somebody is going into shock, we want to start treating them for it to essentially increase the risk or the chance that they're going to survive, right? We want to help their body compensate. We do not want to let them start decompensating. So here are some signs and symptoms of somebody who is compensating, right? Oftentimes they're going to feel agitated or anxious or restless because they know instinctively, or at least their body knows, that something bad is happening. Now, another pretty clear sign that somebody is having something wrong is this sense of feeling of impending doom, right? If your patient who has chest pain and you are suspecting that they're having a heart attack, if they look at you and they're like, hey, I feel like something's wrong, I feel like I'm going to die, that is a great sign that something is actually wrong, right? There's a big difference between, oh, haha, I'm dead, right? Oh, I'm going to die, you're so funny. And then also like, hey man, I really don't feel good, I think something's wrong. That is a very clear sign that that person is experiencing shock. They could also be altered, so they could be kind of confused or not sure what's going on. Another big one is like cool skin to the touch. They might be sweaty, and you might have a hard time like feeling their pulse. It's still there, but it's not going to be as easily accessible. They could be shortness of breath. They could have delayed capillary refill. They could feel nauseous. There is just a wide range of things that somebody could be feeling depending on what is causing their shock. Another big one is that they feel really, really thirsty, especially after bleeding, if we're talking about like hypovolemic, because their body knows they need fluids, and it's basically using up all the fluids that it has to try to compensate, so they might feel very thirsty as well. All of these are signs that we want to start treating them for shock, that we want to help them stay in this compensated state. We want their body to continue to try to stay normal, to try to stay alive. If we don't start treating them, it's going to get worse. And there is a point where it's too late for us to do anything if we don't let them compensate or we don't help them compensate. So that's one of our big pointers here is if you think that somebody's compensating, we want to help them compensate. So we don't want to wait until we see signs of their blood pressure dropping or other worse signs coming up to start treating them for shock. We want to do it sooner rather than later. Because if they're going into decompensated shock, that tells us their body is starting to fail. They are starting to go towards death. So we won't see signs of decompensation until it's too late, essentially. Their blood pressure falling. We don't want to wait until we see that to start treating them. They're going to start having harder time breathing. They're probably going to go more unresponsive, be more lethargic, and not be able to respond. Their pulse might be in and out, like it might be still weak, but you don't feel it for a period of 10 seconds, and then you kind of are able to feel it come back in. And their skin is going to get more and more pale. It's going to get more and more cyanotic, right? Because they're not able to circulate that blood. Okay, so all these are really bad signs. We don't really want to let it get to this point, because when people start to decompensate, they quickly move out of what we call decompensated shock into what we call irreversible shock. So even if that person is still technically alive, if they're in this stage, like no matter how much work we try to do in the hospital, like with blood transfusions or fixing the injuries, no matter what we do, it's probably not going to be enough. So our goal is to always keep them out of this stage. We want them to stay in compensation, and we can do that by alleviating some of the body's effort it's exerting to stay compensating. So again, how we treat that shock is actually pretty straightforward. we're going to want to make sure that an EMT at least is on the way so they can administer oxygen. But what you're going to do is keep them nice and warm. You're going to stop any external bleeding you see first. You're going to put some blankets underneath them if they're laying on the ground. And you're going to put some blankets on top. And you're going to want to lay them flat supine, right? Remember that when we're preserving their body heat, we're making their body have an easier time preserving its energy. Creating our own body heat, this takes a lot of effort for the body to do. So if we can remove some of the effort it needs to create body heat, we're going to have it focus more of its energy on being able to circulate that blood. Pumping them full of oxygen is going to help their cells keep going, because if they're not getting enough oxygen, we can really just push it into them so that they can have more. And that laying them supine takes all the effort that their heart has away from trying to fight against gravity. Remember, if I'm standing up, my heart has to work a little bit harder to pull blood up from my feet, but fighting against gravity, versus if they're flat down, it's just all kind of circulating on the same level. We want to get them going to the hospital as soon as we can, because the sooner they can get to advanced life support, the sooner the immediate problem can be fixed. And then this thing down here at the bottom, PFA. This stands for psychological first aid. And this is really simple. This is just being a person there, speaking to them, keeping them calm, explaining what's happening. If you've ever been really scared after an injury or anything like that, if you've ever had to be in an ambulance, hopefully not, but this is actually one of the more important things that we can do that people don't really realize. It's just being a calm presence, being honest with them, saying, hey, it looks bad, we're doing everything that we can, this is what we're doing, I'm here, keep talking to me, what can we do, all that kind of stuff. It does make a huge difference. And part of being a VEFR, part of being in emergency medicine, is being the calmest cat in the cafeteria 24/7. If you are calm, even in really stressful situations, the person who you are treating is going to feel better. They're going to feel more secure. It's not going to fix the problem, but it does help quite a bit. So that's actually a really big skill that you guys are going to have to learn if you go into emergency medicine, is how to remain calm even if you don't feel calm on the inside, right? And one of the best things you can always do, no matter what the situation is take nice, deep breaths in through your nose and out through your mouth. Even on the situations that I was the most scared, right, on calls, I would force myself to because it regulates your emotions a little bit, gives you more oxygen, keeps your stuff going well, and it's really incredibly important to do so. So don't count that out. Now, let's say that we are bringing a patient up to the hospital. If they just had a traumatic accident, what the hospital really wants to know is any of these sort of things. What they can do is essentially call a trauma alert, which means at UVM, a level 1 trauma center, they can manage pretty much any injury 24/7, 365, but they need an update on when to do that. They don't just keep everybody in the hospital at all times, but if we call ahead and we let them know about a severe patient coming in, they can call out and get everything ready that we need. So they really want to know about any sort of low blood pressure, anything below 90 on that top number, that's systolic. They want to know if anybody is having respiratory compromise. So if their breathing is less than 10 breaths per minute or more than 30 after a traumatic accident, that's a big deal. If there is any sort of amputation, they want to know about that as well. And if there's any sort of penetrating injury to the chest, neck, or abdomen, those are also really big, bad situations. Evie, are paramedics or someone on the ambulance certified to give blood transfusion if a patient has a severe blood loss? No, not in Vermont currently. Some of the challenges with this is we would have to store blood on our ambulance. It's actually really difficult to store blood. It needs to be at the perfect temperature in a sealed container. Ambulances are outside most of the time, and even with air conditioning and things like that, it's just really hard for us to keep blood safe on an ambulance. There has been some work into this. So depending on how future things go, remember EMS is constantly adapting and changing. This is one of those things that we hope we can do in the future, because it could help a lot. Paramedics potentially could do blood transfusions, but currently we don't do it in Vermont. So it's one of the things we're hoping to move for. At GIV, will we learn how to use communication? Yes. Yeah. We're not really going to practice with radios or anything like that, but we are going to practice on how to talk to each other and give reports in like a medical sense. Now, some other tools we have in the events of trauma are transportation devices, ways that we can lift people up and move them from where they were injured to our stretcher. Now, these two things, shortboards and longboards, they have changed quite a bit. We don't typically use them as much as we used to. We used to essentially like fully immobilize anybody who had a head, neck, or back pain after an injury to one of these short boards or these long boards. And this is just kind of a funny video from when I was in EMT class, and my friend puts me in one of these a little bit too tightly, just scrunches my face. It's more of an example of what not to do. But we used to be able to like immobilize people, and that was our goal, was to make sure they didn't have any worse spinal cord injuries. However, we have learned some stuff since then. So we used to, anytime anybody had the slightest pain in their head, their neck, or their back after a traumatic injury, we used to lay them down on a rigid board and strap them to it so they couldn't move at all. All right. The idea was immobilize the spine, make it so it doesn't move anymore. However, human spines aren't naturally straight. There are some curves to it. And the board that we put them on was totally straight and rigid. So doing medical studies, we learned and we figured out that people with spinal cord injuries strapped to backboards, immobilized, their pain increased, the severity of their injury increased, and they also didn't like us very much, because you put someone on a rigid backboard who has a spinal cord injury. You're moving around, you're in the back of the ambulance and it's bouncing. It made things worse. So we don't really use backboards like we used to. What we do use backboards for is that they are a really great, easy way to essentially put somebody on them, pick them up, move them quickly, and then put them back down on our stretcher. So that's what we're going to be using backboards for. We're going to practice that at the Institute. But for the most part, what we do now is something called spinal motion restriction. All right. So we don't have to put a C-collar on somebody, but we're going to do an assessment to see after an injury if they might need one. And then instead of laying them on a hard, rigid backboard, we're going to lay them on our stretcher, nice and flat, because a soft surface is going to conform more to their back and to their spine, and it's actually going to provide more support than a backboard would. So this is the flow chart that we essentially use to determine if somebody needs a C-collar. So basically, we're going to go down this assessment, and if at any point there's a yes, we just stop the assessment and we put them with a C-collar on. But if we get to the end and they didn't have any yeses, they didn't fail any part of the assessment, then they don't need one. So first things first, if there was a mechanism of injury that could cause a spinal cord injury, we're going to be suspicious and we're going to start the idea of this assessment. Now, the first one is that we can't essentially do this on a child, because they might not be able to answer the questions as appropriately. And so anybody under the age of 18, we essentially just put a C-collar on just to be sure. Yes, Zoe, you can put C-collars on as VEFRs. That's why I'm explaining this to you. After that, if they're over 18, right? If they're too uncomfortable, if they're too anxious to respond, or they're having difficulty understanding us, like maybe there's a language barrier, we are just going to play it safe and put a C-collar on and transport them. After that, if there's any sign of altered mental status or intoxication, right? If somebody was in a car accident and they were drunk, but they're not reporting any pain, we're not going to trust it, because alcohol and other drugs, intoxicants, can suppress people's pain responses. So if they're intoxicated or they're altered, we are just putting a C-collar on and moving down. Now, the next one here, distracting injuries to patient or others. This one's kind of interesting. So if somebody was in a car accident and they have a really bad broken leg that is causing them a lot of pain, we essentially are going to assume that the level of pain in their broken leg would dull any pain that they might be feeling in their head, neck, or back, and they might not be able to recognize it. So if they have a distracting injury, we're going to just play it safe and we're going to put a C-collar on. Now, this also means if there's somebody else in their car who is severely injured, they might be distracted by that person's injuries too much to recognize their own. So let's say like a dad is driving with his daughter and they get in a car accident and the daughter has a bad broken leg and she's screaming in pain. The dad is probably going to be worried about her more than he is about himself, so he might not be able to feel any pain or notice any pain in his head, neck, or back. So if that's the case, we're going to put a C-collar on him just to be sure. Now, once we've essentially gotten through these four things, if they're not a child, they're an adult, they're totally cooperative, they're understanding us, they're not altered or intoxicated, and there are no distracting injuries, now we're actually going to start assessing their body. So if there's any abnormal neurological function, so if they can't move their fingers or their toes, or if they feel tingling or numbness in their fingers or their toes, they fail that, they get a C-collar. If they're normal, they don't feel anything weird in their hands or their feet, then we can carefully start palpating down their spine, which means like touching their neck, feeling their spine all the way down their back. If at any point they say, ow, or yeah, something feels weird, or you feel like a step off, like something feels broken to you, they get a C-collar. Now, if there isn't any pain on that palpation, then we're going to move to the very last step, which is essentially we're going to have the patient try to flex and extend and then rotate their neck slowly. So essentially, if we get to this point and say, okay, go ahead and turn your head slowly to each side. If you feel any pain, stop and bring it back to the middle. You get a C-collar. If they can go to the side with no pain, then we have them look forward and back. And if there's no pain at all there, then we can have a conversation with them. It's like, okay, I don't think you have a head, neck, or back injury. Do you want to go to the hospital, right? But if they fail at any point, if they feel any sort of pain, they get a C-collar, right? And I'm going to teach you how to physically do this, how to apply a C-collar at the Institute. But in general, we're always going to have somebody holding their neck in line while we are getting the collar ready. So somebody comes from behind usually and holds what we call holding C-spine. So it's hard to do it on myself, but you come from behind somebody and you put your hands essentially underneath the sides of their neck, and you're just basically trying to keep their head nice and straight. If they're trying to move their head, really don't let them. Just have it stay nice and straight. That's the best way to do it. We're then going to essentially size the C-collar. You can change the size of it based off of somebody else. And then you want to rest it against their sternum, and then it's going to Velcro around their neck. And it's basically just going to mean it's not going to 100% stop them from moving their head, but it's going to make it a lot harder for them to do so. And so they're going to want to try to turn like this if they're going to turn at all, right? We need to protect that cervical spine. So again, this is going to be a big part of what we do at GIV. Yes, Joe, anytime you are treating a child, you still need guidance, like parental permission, okay? Again, if the parent isn't there, we try to contact them. If we can't contact them, we treat that child under implied consent. But we still, if the kid is in the car with the parent, I'm going to ask the parent, do you give me permission to treat your child, right? That's baseline. We always have to do that. No matter what we're doing, we have to get parental permission. We always have to get consent. Okay. Any questions about traumatic injuries before we move on to cardiac arrest? That would be implied consent, Aubrey. If the parent can't respond, we're going to treat them with implied consent, and we're also going to treat that kid. Any other questions? Yes. You only need one parent's consent, whoever is there, or whoever you're able to contact, as long as they are their guardian. That's a tricky situation. Like if one parent says no, one parent says yes, I'm going to go based off of the parent who's making the correct decision and wants care for their child. Okay, cardiac arrest. Now, this is a timeline of every single cardiac arrest call that I have been on. I have been on dozens. All right. And I've kind of accumulated them together to give you a rundown and to point out something to you. So first things first, unfortunately, somebody needs to go into cardiac arrest, right? That can be caused by a multitude of different reasons. We'll say in this case, a heart attack. Now, the 2 to question mark minutes is how long it takes for someone to call 911, right? Oftentimes, if people are not familiar with medicine and someone kind of collapses, I'd say it takes people around a minute to 2 minutes to like call 911 and get the thing going. Like if for some reason I just collapsed, right? You guys would probably spend about 2 minutes being like, where's Kevin? What's he doing? Did he just like fall down? Is he okay? What's going on? And then maybe 2 minutes later, one of you would call 911 and be like, hey, I don't know I don't know where he is. He says he's in Denver, but you know, my instructor just collapsed and I don't know what's going on. It would probably take you about 2 minutes to call. After that, an ambulance is dispatched, right? 911 is called. We get sent out to that location. Now, depending on where you are, it could be like a 5-minute trip to a 30-minute trip. If you are in South Burlington, right? South Burlington Rescue is right on Dorset Street. So probably about 5 to 10 minutes depending on where you live in that area. Versus if you're somewhere out more rural, right? Depending on where that ambulance is, it could be upwards of like 30 minutes. On St. Mike's, we used to respond to Heinsberg, which was minimum 25 minutes away, lights and sirens on the highway. But when we arrive, we're going to do an assessment. If CPR is necessary, we're going to start it. And our protocols say that we're going to do CPR for around 25 minutes on scene before we decide either to transport or declare that person dead. If we decide to transport, it's another 5 to 30 minutes to the hospital while we're doing compressions. And then they arrive at the hospital where they get secondary care. Now, here's my question to you. How many minutes can the brain survive without blood flow before brain tissue starts to exponentially die? How many minutes? Give your best guess if you don't know. 2, longer than that. 5, closer. It's actually 6. So if you said 5 or 7, you're right in the right vein. It's around 6 minutes. Now, looking at this chart, on the most optimistic of days, where it takes 2 minutes for 911 to be called, and then 5 minutes for an ambulance to get there, how many minutes is that? 5 plus 2. 7. Even on the best day, even when we are the quickest we can be, we are still a minute too late. That's where you come in. That's where community members come in. That's where VEFRs come in. Because if you are the person on scene who recognizes that somebody's in cardiac arrest and you start doing compressions before we get there, you will save that person's life or have a higher chance to, right? Unfortunately, on a lot of these calls that I went to, cardiac arrests, we'd get there as fast as we could, but sometimes it was 10, 15, 30 minutes, right? I knock on the door, they open the door and they say, oh, thank God, finally somebody who can help is here. Yeah, they're right over there. And I look at my watch and I say, okay, we'll do our best, right? But it's been 15 minutes and their brain tissue is probably dead, right? We might be able to get their heart beating again, but the chances that they wake up and go back to normal are incredibly slim. So that's why it's so important to recognize and quickly do CPR. Because when we do CPR, when we're compressing on someone's chest, we physically become their heart. We circulate their blood. So cardiac arrest itself, this doesn't mean that the heart is completely stopped moving. In fact, we hope that there's still a little bit of electrical activity going in. Specifically, 2 types of rhythms that an AED can shock are called VFib and VTAC. You're not going to feel a pulse. That person is still clinically dead, but if they still have a little electricity in their heart, they're more likely able to get a normal rhythm back. Okay? Now, it might sound rough when I say it like this, but all you are doing when you are doing compressions on somebody in cardiac arrest is preserving a corpse. Their heart is not beating. when you compress on their chest, you physically become their heart. You pump their blood around their body. You are keeping their internal tissues, their heart, their brain, their liver, their kidneys, their spleens, all of it. You are keeping it receptive to life. You are keeping it prolonged. Okay? So just doing compressions by itself is not going to be enough to bring them back, but it does prolong the time that we can keep them, or prolong the time that we can get them back with extra help. So if somebody is not breathing, or they're exhibiting those agonal gasps I showed you the video of a few days ago, and you do not feel a pulse, the treatment is CPR. And you need to do that as soon as you can, as soon as you recognize that they have no heartbeat and that they need to circulate. Because your heart is beating in your chest, it gives you control over this meat sack we call a body, and if all you have to do is press down and compress on their chest to circulate their blood, that's pretty easy to do, right? And you could end up saving this person's life. So the treatment when somebody's in cardiac arrest is what we call high performance CPR. If you have learned CPR in the past couple of years or so, you've probably been taught to do 30 compressions, stop, give 2 breaths, go back, give 30 compressions, stop, and give 2 breaths. Well, Vermont is actually part of what we call a pilot program. So we do CPR a little bit differently. We do not put as much emphasis on breathing as we used to. And in fact, we prefer continuous compressions. We want to minimize the amount of time that we are not doing compressions, right? If you take 2 breaths right now, did you stop your heart to do that? No. Why would you? So why would we do that for somebody who's in cardiac arrest? In fact, it makes things worse. We just want to do continuous compressions so we can circulate somebody's blood. And then when we attach an AED, we can potentially shock their heart back into a normal rhythm. So the whole goal here is continuous compressions, minimize time spent off of the chest, early defibrillation as best as we can, applying an AED and shocking them as soon as we can, and we want to maximize our available providers. So we call it a pit crew style, where we're constantly rotating who is doing compressions so that we have a fresh set of hands to do it. CPR, it's kind of actually challenging to do. It is a little bit of physical activity. If you try to do it for a long period of time, you're going to get tired and your quality of compressions is going to take a nosedive. So we always essentially have somebody who's ready and fresh next in line to jump onto that the chest. We also focus on basic things, BLS, basic life support, before we start moving to advanced things. So even if 2 paramedics were the first people on scene for a cardiac arrest, they are going to take the roles of compressor and AED. They're not going to give medications. They're not going to start ventilating that person. They're just going to manage those 2 positions until more people show up. And once the other roles are filled, then those paramedics can take a step back, start doing an IV, do an IO, give some medications. So this is what pit crew style looks like, right? Here's our patient in cardiac arrest. The first person is always going to be doing compressions. That's our first step. Circulate their blood, keep their blood moving. After that, the next person to arrive is going to manage the AED, because these are the 2 most important things when it comes to cardiac arrest. Any other providers that show up after that, the next position is going to be the airway. So once we have enough people, we will start giving some oxygen, but only after we have enough. And then anybody else who shows up is essentially going to take steps back. An ALS provider will start giving some medications. They might attach a more in-depth AED to look at some heart rhythms. And then we also really want somebody who is in charge, somebody who's taking notes, documenting everything, and making sure everything is moving smoothly. If anybody else shows up, I'm just going to put them in line directly here, right? Essentially, someone's doing compressions. Let's say this is an ambulance crew, and then a fire company shows up with 8 dudes or 8 different people to show up to help. I'm going to say, get in line, get in a single file line behind the person doing compressions. And then every time we switch, that person goes to the end of the line, the next person steps up and does compressions. So we essentially just have this line of fresh people ready to do compressions. This is really important that we stick to this, because if we prioritize other things before the compressions and the AED, we're doing a disservice to this patient. We're decreasing their chances of survival. Now, I just put this link up here if you wanted to look into it, because we are doing what we call a pilot program. High performance CPR is not taught by the people who give CPR certifications, like the AHA or the Red Cross, because it's still new. We are actively participating right now in a medical study. So all the people we do cardiac arrest work on Vermont, those cases are put into this study, and essentially we're trying to prove that this is a better way to do CPR. It's actually showing some really good outcomes. People who get 30 compressions to 2 ventilations CPR have about 10% chance of surviving a year after their cardiac arrest. Patients who are getting high performance CPR are having a 30 to 40% chance of surviving a year after their cardiac arrest. If you know anything about medical studies, that's insane. We never see a big jump like that. So this is just supporting us, saying that what we're doing here is actually a better way to do CPR. So if you're going to be a first responder in Vermont, this is what we're doing. Now, the reason this is so important is because when we circulate that blood, we can keep somebody's blood pressure high enough to support life, right? Here's somebody's blood pressure who's alive, right? All of us right now. This is the blood pressure to support life. Here's somebody who's in cardiac arrest. If we do 30 compressions and we stop, the pressure drops really quickly. So even if we're doing 30 compressions, 2 ventilations, 30 compressions, 2 ventilations, right? We're never going to keep them up at that line. Versus if we do continuous compressions for 2 minutes and then the AED analyzes and we stop for 10 seconds, we're keeping them at that level that actually supports their life. Now, I'm going to tell you a quick story. In 2015, this was the first year that we started doing high performance CPR, so 10 years ago now. That's also a testament to how long medical studies need to happen for. The first person we did this on was the Richmond police chief. He went into cardiac arrest during a high-speed car chase in the back roads of Vermont. He was driving, chasing a guy going like 80 miles an hour. He started having chest pain, pulled over to the side of the road, radioed for help, and then died. Went into cardiac arrest. Luckily, he radioed for help first. Somebody pulled him out of his car, started doing compressions, and the ambulance was right there. They picked him up. They were just doing compressions. They had a paramedic. They were not giving him oxygen. They were not giving him medications. They were just doing compressions and shocking him with an AED. They're doing that from Richmond. So like 20 minutes up to the hospital, 20 to 30 minutes. About 5 minutes away from the emergency room, they're doing compressions. They look at the monitor and they see no electrical activity in his heart. They see a flat line, right? But the chief opens his eyes. And sometimes these things can happen in cardiac arrest where like they open a little bit or like they're partially open, but no, he opens his eyes. They continue to do compressions and they say, Chief, if you can hear us, blink twice. And he goes. So they stop. They think something's wrong. They take their hands off their chest and they look at the monitor thinking that he might have a heartbeat. The monitor is flatline and he's now back unconscious. They did such good compressions. They provided him a blood pressure high enough to return him to consciousness without his own heart having a beat. They physically became his heart. That is why this stuff is so cool. We have coined new terms. CPR-induced consciousness. People waking up during CPR because they're doing such good compressions. That's insane, right? That's why compressions are so important. And then when we essentially attach an AED and we can shock their heart back into a normal rhythm, that is the priority. Yeah, I'll put the link in. I'll put it in. Here, I'll just do it now. Messing up my flow, but it's fine. That's also an old study. I put this together a while ago, so there might be some newer ones too if you want to look into it. Now, so an AED, this is a device that we apply to somebody's chest that registers their heart rhythm, right? If there are one of those two rhythms, VTach or VFib, the AED will want to shock them, because if we essentially shock one of those rhythms, we have the chance of putting them back into a normal heart rate. An AED is essentially like a slap in the face for the heart. It says, get your crap together, start working again. And that's the goal. We provide it with a shock, and it goes back to normal. It will not shock the patient if there's a flat line, right? It will only shock if it registers that there's a little bit of electrical activity. So when we're doing compressions, we apply an AED to the person's chest, and the only time we actually really stop doing those compressions is when we are letting the AED analyze their heart rhythm, so it can tell us if it needs a shock or if it needs not to shock. So again, here are those two rhythms. Ventricular fibrillation is VTach, or VFib, sorry. And it's essentially like disorganized electrical signals, like the heart kind of looks like it's twitching. I'll show you a picture in a minute. And then VTach, ventricular tachycardia, is that those ventricles, the bottom parts of the heart, are just beating too fast to actually allow blood in. So it's just moving really, really quickly and no blood is being circulated. Here's what they look like. That's actually a heart and VFib. So there's electrical activity going through, but it's just twitching, kind of looks like a bag of worms, right? Whereas ventricular tachycardia, these two ventricles at the bottom are beating way too fast and it's not allowing any blood in, so there's no blood circulating and we will not be able to feel a pulse. So an AED will recognize these and then it can shock them, hopefully back into a normal rhythm. Whereas it won't do that for asystole. This is the only heart rhythm that we, as EMTs and VEFRs, can register because it's really easy to. It's just a flat line. If you see it on a monitor, you know that there's no heart activity at all. But it's not going to shock them. Life isn't Grey's Anatomy, guys. That's one of the things you always see on TV where it's like, he's flatlining, spark him, and they go, poof, poof, and then the patient wakes up and is like, oh, I love you, right? That's always how it goes. But that's not how it works in real life. They have to have electronical activity in their heart for the shock to work. But how do we go about determining if somebody needs CPR? It's going to be a little bit of an assessment. It is relatively easy to tell, though. They are not going to be responsive. They're not going to wake up to verbal or painful stimulus. We're always going to treat somebody who's unconscious like they could be asleep to start. So I'm not going to run up to somebody who's like on the ground sleeping and start doing compressions, because they might be able to be like, oh, ow, right? And you're going to say, oops, my bad. So I'm always going to call out to them, hey, are you okay? If they don't respond to that, then I'll go over and I'll administer some of that pain. Hey, are you okay? If they don't respond to that, I'll go to my ABC assessment, right? I'm going to feel for a pulse. I'm going to look at their chest rise and fall. If they're not present, I need to start CPR. Is there any way to save people with unshockable rhythms? CPR, right? If we do compressions, we circulate the blood, the heart might start one of those shockable rhythms again. But if they never go into a shockable rhythm, no, there is no way, unfortunately. So as soon as we recognize that we need to start CPR, we need to call for help. We want to make sure that as many people as can be are on their way so that we can have a lot of people to do compressions, have people to use an AED. If you don't have an AED with you, tell someone to get one, right? Now, here's the other thing. There is a little bit of a caveat on when we do CPR, okay? If they don't have a pulse, but they were put into cardiac arrest by a physical injury, we don't do CPR, okay? This is part of our assessment, too. So if we show up, like we might find somebody who has been dead for too long of a time for CPR to work. So if they were put into cardiac arrest based off of blunt or penetrating trauma, like they were shot, or they were stabbed, or they were struck by a car, and we find them with no pulse and no breathing, they're dead, okay? We can't fix their body if it's just destroyed, right? So the other thing that we're looking for is like we might be called because a welfare check. This has happened plenty of times where we get called like, hey, I haven't heard from this person in a few days. Could you go check on them? We go check, we find somebody who's dead, and it's been a few days. We can't do CPR on them. So if we find any factors of decomposition, somebody is starting to degrade, mold, really, really bad smell, bloating, liquefaction, really gross stuff, don't start CPR. If they have been decapitated, if their head is no longer attached to their body, CPR is not going to help. This also includes like exposed brain matter. If their brain is not in their body, CPR is not going to help. If they were killed by being burned, what we call incineration, CPR is not going to help. And then if we see what we call rigor mortis or dependent lividity, rigor mortis is something that happens in the, probably like 30 minutes to an hour after somebody is in cardiac arrest. Their body essentially becomes rigid. So you might move their arm and it might stay up. You might find their hand clenched, and when you move their fingers, it's like an action figure, right? You just move it in whatever position you move it in, they stay. That's a sign that they've been dead for too long for CPR to work. And then lividity, this is essentially the pooling of blood at the lowest area. So if somebody was on their back and we find them and we roll them to check their back, we would likely see like dark purple on their back because the blood in their body has congealed towards the lowest part. So it's tough. It really sucks. But if we find somebody who's dead, we need to check for these things really quickly first before we start CPR. Because if we find any of these things, it's mainly traumatizing us, right? If we make people do cardiac arrest for 25 minutes on somebody who it's not going to help, that's just really bad for us too. And it's not helping that patient. So in this case, if you see any of these things, we just don't even start CPR. If you have started CPR and then you find these things, we stop. Okay? Now, let's say you didn't find any factors of death, right? They're pulseless, they're apneic, they're not breathing. You want to start CPR. You put gloves on, okay? Call for advanced life support. Call for as many other people as you can. Cardiac arrest calls typically get a wide response. Fire, police, EMS, because we need as many people as we can get on these scenes to essentially make it work. And then we're going to start those compressions and we're going to apply an AED. Now, when we get to, so Molly, it's got to be an EMT, right? Again, you guys as VEFRs are not going to be the people who are in charge of these calls. If you're on an ambulance, you're going to have what we call a crew chief who will make those decisions for you. But if for some reason you're like by yourself and you will come across somebody, if they have those factors of death, don't start CPR, but you're going to be essentially working with a crew and then your crew will make the decision together, of what to do. Okay. We're also going to go over like exactly how to do CPR at the Institute. So we also have to apply the AED. Now we have to put this directly onto their bare skin of their chest, okay? This is actually one of the biggest barriers we find in bystander CPR because a lot of people, especially in the cases of males providing CPR to females in cardiac arrest, they are afraid of being considered like a predator or a creepy person for removing the top layer of clothing on these people. These pads need to be applied directly to bare skin. Clothes cannot be in the way. We always remove every layer of clothing on the top layer of that, on the top part of that person's body. Okay, it needs to go onto their chest. So if you are a guy or anybody who's worried about that, if somebody is accusing you of doing something wrong when somebody's in cardiac arrest because you're trying to apply an AED, they are clearly uneducated on how CPR works. All right, you are doing the correct thing. It can be uncomfortable, but that's what we have to do. So you apply the pads to the person's chest. One pad goes on their right shoulder or the right, part of their chest right here. And then the other one goes on their left flank. Yes, Joe, you can apply an AED. So you put them onto the chest, and what you're doing is you're trying to create a straight line between their heart and these pads because it's essentially just like a positive and negative feed. So when you hit shock, it's going to go through the heart rather than around it. Evie, that's a great question, and I'm going to get to that in just a minute. So once you apply the pads, make sure they're stuck to the chest, turn on the AED, and it's going to automatically start analyzing their heart rhythm. Again, when the AED says analyzing, That's like the only time we want our hands off the chest so that it can register their heart rhythm. If we're compressing and it's analyzing, we can mess it up and it might not be able to like actually assess what's going on. And then it's going to either tell you no shock advised. So if it says that, just continue CPR, and it's going to automatically analyze every 2 minutes. Or it might say shock advised, in which we're going to do 30 compressions while it charges, and then we'll administer the shock when nobody's touching the patient. Yes, you can help set up the monitor if it's the AED pads. That is just an AED, right? We have cardiac monitors for multiple different reasons. It also works as an AED. You can apply AED pads. Okay. Is this the slide you wanted, Zoe? Okay. Now, AEDs can be kind of dangerous if we don't use them correctly. They put out a large amount of electricity. So, what might be some times that we do not want to shock somebody? What do you think? So, you guys are close to it. If they are wet on their skin, we can dry them off, and that's fine. If they're near water, that's okay. But if they're in a puddle and you are touching the same puddle that they are touching when you hit shock, you will receive the same amount of shock. Rain is okay because it's not it's not a pool of water, right? If they've got droplets on their chest, just dry it off and apply the pads, but it's not a danger to you unless they are in a puddle that you are also touching. If they're in a puddle, move them out of it, dry their chest off as best you can, but rain is okay. You just want to keep their chest, it doesn't have to be bone dry, just not like sopping wet. If somebody else is touching them, absolutely. If you are touching the patient when the shock is delivered, you will receive the same amount of shock that that patient does, and it can be very detrimental. It could be deadly, right? You don't need that level of shock. What else? Water. That's a good question, but that would make me concerned that they were put into cardiac arrest by a traumatic situation in which I wouldn't be doing CPR, right, Taylor? If they were killed because they have a big open wound in their chest, that would mean we wouldn't be doing CPR in general. Oh, and yes, if they have a pacemaker. So a pacemaker or an internal defibrillator is a little device that is implanted into somebody's chest, usually based off of some previous cardiac arrest history. They oftentimes present as like little lumps or ovals or rectangles underneath the skin in that area where we want to put a pad. So we're not going to put the pad directly over it. We can still shock somebody with a pacemaker, but we don't want the pad directly on it. We want to move it down just a little bit. Okay, just don't put the pad directly over that device. That's one of those times that you could actually make somebody more dead, is if you shock directly a pacemaker, because they can explode. Okay, like a little, and that's not good. All right. Other things that conduct electricity are things like metal. So if there's a metal floor that you're kneeling on, we want to move them out of that area before we shock them. Now, we're going to be practicing in Vermont. What about snow? Can we shock somebody on snow? What do you think? Why not? Is snow water? You might be surprised. Snow is not water. The chemical function of water changes when it freezes. Snow does not conduct electricity. You can shock on snow. All right? I saw some good things come up here. Yes, you can shock children. Hibbo, if they have a DNR, we're just not going to start CPR in general. That's another thing we'll talk a little bit more about at GIV. But a DNR is essentially what we call a do not resuscitate order, where somebody has talked with their doctor and their family and they have decided, if I go into cardiac arrest, just let me die. I don't want any help, right? So if somebody hands me a signed DNR document, I will not do CPR. If someone just says they have a DNR, I will start CPR and say, I will stop when you bring me the signed document. Okay. What if the patient got put into cardiac arrest due to a heart attack or something which caused a traumatic injury? That's a great question. That's going to be up to you to essentially assess for. So if somebody's driving a car, right, and they have a heart attack and die and they crash the car, I'm going to look at their body, and if I see that I don't see any major signs of trauma that lines up with enough for somebody to be put into cardiac arrest, I'm going to start. And that definitely happens, right? It's all about the physical signs of trauma. It is going to be very easy to tell if somebody was killed in a traumatic way that put them into cardiac arrest. You are going to look at them and say, oh boy, they're dead. Okay? Yeah, so snow is fine. Can you use an AED on someone who drowned? Yes, absolutely, as long as they are not in a puddle of water. So metal floors. If you do any of that stuff, you're going to look like this, right? Now, I apologize. I did have to use a picture of myself for this this presentation here. We'll get to it. This one right here. Evie, this is the one you were asking about. But if your patient has a lot of chest hair, right, really thick body hair, you might need to remove that body hair in the areas of where you put the pads. Because the chest hair can get in the way of the pads sticking directly to that person's chest. So if that's the case, most AEDs come with little tiny razor blades to shave the area. If you don't have one of those shavers and you have 2 sets of pads, put the first set of pads on, rip it off like a wax strip, and then apply the next set of pads in those areas so that it sticks to the chest. Right? It might seem kind of outlandish, but I have seen it happen. I was the second arriving ambulance for a cardiac arrest. The first crew put the pads on the guy's chest. He was incredibly hairy. The monitor said, yep, all good. I'm reading his heart rhythm. But they didn't notice that the pads were hovering just like a millimeter off of his chest. So when they hit shock, I watched flame go whoosh across his chest, melt the hair and the pads to him. Okay? So don't be afraid to remove chest hair. I would much rather wake up in the hospital looking like this than not wake up at all. Okay? Now, so other things we want to pay attention to. Like we said, this is a pacemaker, right? So you might see like a implanted device underneath their skin. Again, don't put the pad directly over it. Okay, you can just move the pad down. Another thing we want to be aware of are medication patches, right? Sometimes the adhesive on these medication patches or the medication itself can be flammable. People do take nitroglycerin, right? That blood pressure medication that is also dynamite through these patches. So we want to remove them with a gloved hand and wipe away the residue before we shock them. Okay? Again, we're always going to be very careful. So that's why in movies you see people before they shock them say, clear, right? But in movies, people say clear in the way that's telling everyone to get out of the way or you're going to get shocked, right? They say clear because they're about to do it. They don't check to make sure no one's touching. We say clear that we have made sure that no one is touching it. So before I hit shock, I am looking around the patient and I say everyone is clear. That means I am shocking. I'm not saying clear to get people out of the way. If they have another electrical thing in their body, it's not going to be an issue as long as we don't put the pad directly over that device, right? And we're only putting pads right here and right here. Diabetes devices are okay, like a Dexcom or an insulin pump, not a problem. Okay, good questions. So again, AEDs can be dangerous, but as long as you're not touching them, you stay away from water, you stay away from metal floors, you should be okay. All right? Again, we're going to practice this a lot at the Institute. Now, there's some other things that I just want to let you know that Vermont does a little bit differently. Now, again, you are not going to be in charge of these calls, so it's not within your scope of practice to essentially do what we call termination of resuscitation, where if we start CPR and it doesn't work, EMTs and up can essentially say, okay, we're not going to transport this patient to the hospital. We tried our best. They're clinically dead. Other things we can do is send pictures of the EKGs that we take up to the hospital. So like you might be assisting an EMT applying EKG patches. You're not going to be in charge of actually doing it, But in the event that we see a heart attack on their EKG, we can actually send it up to the hospital before we even get there, because some ambulances have most ambulances have a portable internet thing where we can just take a picture of their heart rhythm essentially and send it up to the hospital so that the cardiac wing is ready for us. Now, in the event that you are doing a cardiac arrest work with a crew, right, what we call termination of resuscitation is if we do roughly 20 minutes of CPR and we do not give any shocks, nothing has gotten better, we can call the hospital, talk to a doctor, and essentially declare this person dead, and we wouldn't transport them to the hospital, right? So there are some criteria there on times that we wouldn't do this, but if we show up, we start CPR, we do it for 20 minutes, we don't give any shocks with the AED because it tells us not to, nothing changes with that patient, we're not going to transport them to the hospital because there's really nothing that the hospital can do in that situation, right? They would just start CPR and want to shock them again. There's no secret trick that a hospital can do to get people out of cardiac arrest. Okay, and this can be challenging. The tricky part with termination, TOR, termination of resuscitation, is that if you're on scene, if you are an EMT and you are determining that you are going to terminate your efforts, you are now responsible for telling the parents, the loved ones, whoever it is, why and what's going on. And that can be really, really tough. Okay, I've done that a few times. So essentially, we have to talk to them and say why, which is challenging. But as you are right now as VEFRs, that's not really going to be your job. Okay, so I just wanted to let you know that might be the case. If you are working with EMTs or up and you're doing CPR, they might say, okay, we're going to stop. And we just stop. The crew chief will have a conversation with the family, and you'll essentially leave that patient there. You'll turn it over to law enforcement. Okay. Now, on the other end of this, let's say they get a heart rate back, what we call a return of spontaneous circulation. What do we do after that? What does that mean? Yeah, we transport, and not only that, but we start our assessment all over. We had a dead person with us, and now we have a severely sick person. We have a very high priority patient. Typically, if we get ROSC in the field, they go back into cardiac arrest. So oftentimes, we're going to be doing CPR, stopping CPR because they've got a pulse. And if we have somebody like this, I'm going to assign one person on my crew to essentially sit there with their hand on the pulse the entire time. And as soon as we feel it stop, we go back to CPR, we go back to shocking. But if they get ROSC once, it's likely that they're going to get ROSC again. Okay. And then we just rush them to the hospital where they continue that process. Now, again, so the TOR considerations. If we decide to stop, it's our responsibility to tell the family or whoever is with them. So this is kind of just what I would say, right? When we arrived, we discovered that your loved one was unconscious, they were not breathing, and they did not have a pulse. This tells me that they were dead. We immediately began all efforts to try and resuscitate them, but after providing continuous CPR, breathing for them, and administering medications, there was no change in their condition. I've spoken to the doctors up at the hospital who have assured me that we have done everything that they would do, so I am very sorry to inform you, but your loved one is dead. Okay? Some of the biggest parts about this. We have to say some form of the word dead, died, and not alive, right? They are dead. It might sound kind of brutal, but people need to hear this. People who are grieving, especially in the moment, are not necessarily thinking straight. If you say they've passed on to a better place, you might hear, to the hospital, right? You brought them to the hospital. That's a better place than here. Dead on my floor, right? They're at the hospital where they're alive. One of the first stages of grief is called denial. People are not ready to accept it. Okay? So we do have to be forthcoming, and we have to be honest. That person is dead. Okay? It's tough. I have done this too many times. I really don't like doing it, but I do pride myself in doing a good job at it. Okay? It's really tough. You are the person, or potentially in the future, the person who knows what was going on, who did your best to help them. It's your responsibility to tell them, okay? Any other questions before we move back to Mentimeter and we round out our online sessions? Okay. So that's it, guys. That's all of our online sessions. Thank you for being here every day. Now, I just want to hear from you what really stood out for you. We're going to do this again next year. We've been doing it for the past 3. So far, it's been a lot of fun and gone really well, but I always like getting a little feedback from you. So what stood out to you most about these online sessions? Very long. Yeah, that's one of the things that's challenging because we set it up this way. Because if we did like hour sessions, we'd be doing this for 7 days, right? So we did 4 days with like 2.5-hour sessions. This is also pretty much the length of a college course, right? A college lecture will go about 2.5 hours. Informative, interesting. Thank you, guys. Cardiac arrest. Well, I'm glad to see that the 2 biggest words are positive, informative, and interesting. Lots of information. Opioid lesson. Julian, yeah. Scheduled better for a meal. Yeah, I can see that, but you're also totally welcome to eat while this is going on. Great. I'm going to take an in-depth look at all of these responses in a little bit, just so I can start to tailor some things in the future if this is what you guys think. But I've got a couple more questions. Now that we've kind of gone over some things, what are stuff that you want to learn more about? What are some things that I can spend more time on at the Institute itself? Acronyms, sure. That's also going to be like a little on you. I can only say the acronyms so many times. It's going to be up to you to essentially memorize them and learn them and all that kind of stuff. We're definitely going to spend a lot of time how to communicate with patients. That's one of the first things we're going to do. Hands-on, absolutely. CPR for sure. Trauma care, absolutely. More anatomy, cool. Other fields, yeah, that's going to be everything outside of VEFR, right? It's not just going to be time with me. You're going to spend a lot of time working with other people, all sorts of different medical careers coming in. So my wheelhouse is the VEFR stuff, but you're only going to be with me for 3 hours a day, right? Everyone else, you're going to spend a lot of time learning everything else. In moment situations, like what if you made the wrong call? Sure, we can spend some more time on that, but the whole purpose of this class is so that you don't do that. Mental health, there is a whole section that you could sign up for on that. I would suggest yes. Yeah, if you want to set yourself up for success so that you remember what we talk about, we have a week in between now and being actually at the Institute, so it would be a good idea. Thanks for saying that. Assessing injuries, concussions. We will do some scenarios like role play stuff. It's going to be fun. Hands-on assessments. Pre-existing conditions, sure, we'll spend some more time on that. Awesome. All right, last question for you guys. Now that GIV is a week away, are you feeling ready to jump in? Are you still a little bit nervous, or are you just nervous? Awesome. Well, to the few people here who are just nervous, I guarantee you you're going to feel kind of nervous until we get there, and then once we start getting into things, it's going to be a whole lot of fun. I can promise you that. I too always feel a little bit nervous before GIV because it's a lot of work, right? We show up, we're going to spend a whole week together, we're living in the same space. It is a big change from your norm. But once you get into the swing of it, I promise you it's going to be a lot of fun. So thank you guys. I really appreciate you coming to these online sessions. This makes a huge impact because you're getting certified. If you want to go with it, right, you have now a chance to get into the career of EMS and learn how to help people. So between now and the Institute, make sure that you attend the actual Institute to give the hands-on learning. Complete those 4 online certificates, the NIMS 100-700, Hazmat, and Mandated Reporting. Once you have those certificates, send them to me. You can also rewatch the lectures because I send out the links and all that kind of stuff. If you want to refresh yourself, I could share the slides with you guys if that would help. I can send those out in an email. At any time, if you have questions between now and the Institute, please feel free to email me. I'd be happy to answer them. So once again, thank you, everybody. I'm really looking forward to meeting you in person at the Institute. To the ones of you who kept your camera on, I will probably remember your name. To everybody else, I'm sorry, but I'm not going to remember your name. So just be ready for that. Have a great week. Take care, everybody. I will see you soon. Bye.